Good afternoon, good afternoon, good afternoon, everyone. Thank you so much for joining us today. We are elated to have you all join us for the first webinar of 2023 for the JMHS, Jamaica Midlife Health Society. I am Samuel from Oldgate Solutions, and it is indeed my pleasure to have you all join us. Forgive me for the discussions you may be hearing in my background. So we have for you the wonderful panel that will take you through our wonderful presentations today. And I will now begin by playing first, I believe, our history video of the JMHS, after which, when that video is done, our moderator will take over and lead us through the day.
Welcome to our first meeting this year, first of three from the Life Health, our first conference for the year. The topic this year is prostate cancer and cardiovascular disease, preventing the double dash. And we're one of the few organizations that have a mixture of doctors and non-doctors, so non-medical and doctors. And our colleagues who are presenting for you are presenting just for that reason. And one of the things I know we've been asked about is erectile dysfunction and what we can do about it. Men worry about it a lot, but we also worry about it, cardiovascular, heart attacks, strokes. That's actually in Jamaica, one of our leading cause of this. Actually, it's number one in Jamaica, which is unusual. So we have great speakers tonight, and thank the audience for joining us. We also please join our organization, and we're going to start our symposium, and we're going to have some fun with it. My co-moderator is Miss Magdalena Cooper de News. She may say a few words. as well as start with a prayer.
Good afternoon, everybody from Kingston, Jamaica. For those of you who are outside of Kingston, first of all, we apologize if you got a program saying that it starts at 2 o'clock, because it actually starts at 1 o'clock Jamaica time, 2 o'clock another time anywhere else that you are in the world. So let us pray. Father in heaven, thank you so much for today. Thank you for waking us up. Thank you for the rain we've been getting in Jamaica that has been able to bring back the hills to a sense of a color green. And we really appreciate that. Be with us in this webinar today, so that everyone will learn something from it and we can share it with others for Christ's sake. Amen.
Dr. Brown, over to you.
Thank you very much, Lisa, and thank you very much, Magdalena. Our members on the executive, we can't do without them at all. I use this opportunity on behalf of our executive to invite all of you attending and all those who want to learn something about prostate problems and cardiovascular diseases here this afternoon. Whether you want CME accreditation or not, you're welcome. The Jamaica Midlife Health Society is a registered charitable organization, as you know, and we operate under the auspices of the Medical Association of Jamaica, the MAJ. Our main mission is to promote health at midlife and beyond. So some persons have defined midlife as 25 years or 35 years to about 50. We have expanded it to 55 to 60. Recently, I heard 70 and 75 and 75 plus. I'm just wondering who has been changing the age bracket. Maybe as they get older, they think it's better to increase the age, so they'll be included. But that's a new definition, up to 70, 75 years of age. We have emerged out of the Jamaican Menopause Society in April 2007. The Jamaican Menopause Society existed years ago, about 25, 30 years ago, led by Dr. Denise Bernard Wright and our own Faye. We had a change of name in 2007 because we figured that more persons wanted to know more than just menopause issues. More men want to know about men's health. Other persons want to know about cardiovascular diseases, hypertension, diabetes, etc. Because prior to this, we just focused on issues affecting menopause. So we have broadened our executive membership. We are not just made up of doctors and nurses and all that, but if you're a chartered accountant, you're a lawyer, you're a teacher, you're an executive secretary, anyone who has sound mind, who is interested in leadership and acquiring knowledge, health knowledge to promote and improve their life quality and quantity of life may join. And as we go ahead, the contact numbers and the links will be highlighted so you can join. It's only $2,500 to join for the year. Those who want accreditation for this meeting will pay just $1,500. So this afternoon, as Lisa had said earlier on, this is our first webinar meeting for the year, and it's entitled Cardiovascular Diseases and Prostate Cancer, or prostate diseases, how to deal with them. And we hope you are here to learn and to share. With this, I also say thanks to our sponsors who will be highlighted as you go along, especially to MedInpex, to the National Health Fund, to MyTech Medical, to Abbott, to MSN Pharma, and then to Indus Life Sciences. Without those sponsorship, we would not have been able to make this possible. So I welcome everybody here, the speakers, the participants, the sponsors, and all those who are present and all those who are online. Thank you all, and you are all welcome. Thank you. Lisa, over to you. Magdalena?
Yes, but I was wondering on the program, the overview that was done initially, correct? By Sam?
Yes, it was done already, so you can proceed.
Okay, so now I think Sam has already put the pre-test questions. They will be in the chat. And also we're just going to remind Sam that they're asking for the banking information again to pay for CMEs. At this time, we're going to have the pre-test questions. Sam? Is it in the chat?
Yes, it is.
Perfect. So we'll give them a couple minutes to do the pre-test questions, but we will start with the sponsors highlights. Over to you, Sam.
But before we get to the sponsors highlights, Lisa, why not let's have a light moment, a moment
Go
where
ahead, Magdalena.
So when I was doing my research, I learned very early on in my career that you've got to laugh in order to learn. And when you have the two of them together, you learn even faster. So here's what I found online. Statistically, 9 out of 10 injections are in vain. Oh dear, nobody else laughed?
That's a good one.
I thought so too. I know, it's a really good one. Okay, over now to the sponsors.
Good afternoon, ladies and gentlemen. My name is Tasha Dixon, Medical Representative with Medical Jamaica Limited. Thank you for having me here today at the Jamaica Midlife Health 2023 First CME Accredited Zoom Webinar Symposium to present to you some of our first-class products for healthy living. We have some antihypertensive products on the market, namely our Lysopress, Lysopress HCT, and Lysonorm. But today I'll be focusing on our newly launched product, Amlator. Now, Amlator is our amlodipine and atorvastatin combination, which provides your patients with flexibility for better risk reduction. Amlator is available in 3 strengths, 510, 520, and a 1020 milligram strength. Now, it is known that in Jamaica, 33.8% of the population suffers from hypertension. Amlator will be providing your patient with long-term effects of moderate reduction of cardiovascular disease risk factors, mainly a 10% reduction in blood pressure, 10% reduction in total cholesterol, and an overall 45% reduction in cardiovascular disease. Now, who is suited for Amlator? Patients who are starting therapy who are untreated, substitution therapy, switch therapy, and additional therapy in patients who are already on a similar class drug. Prescribing Amlator for your patients, you will be controlling the blood pressure and high cholesterol. There will also be a 53% risk reduction for non-fatal myocardial infarction and fatal coronary heart disease, a 31% risk reduction for non-fatal and fatal stroke, and also there's convenient dosing, because Amlator can be taken anytime, day or night, regardless of the food intake. Next up, we have Tamsul. This is our brand of tamsulosin in a 0.4 milligram strength. Tamsul is a modified release formulation. It is used for the symptomatic treatment of benign prostatic hyperplasia. Tamsul can also be used off-label for the treatment of ureteral stones, prostatitis, and female voiding dysfunction. But please note that Tamsul is not indicated in hypertension. Tamsul is taken once daily, approximately half an hour following the same meal each day. It can be increased to a 0.8 milligram strength once daily for patients who fail to respond to the 0.4 dosing after 2 to 4 weeks. If for any reason that Tamsul is discontinued or interrupted for several days, the therapy should start again with the 0.4 milligram once daily dose. Tamsul is covered by the NHS, so your patients will be paying approximately $15 per capsule for their treatment. Now I'll be moving on to 2 of our OTC products. The first one is our Sorbifor Duos. Now, what is the indication for Sorbifor? Now, Sorbifor is an iron supplement. It is indicated for the prophylactic treatment of iron deficiency as well as therapy for latent and manifest iron deficiency. How is it taken? For adults and children who are over 12 years of age, it's 1 tablet 2 times daily. In pregnancy, during the first 6 months, a single tablet once daily is taken, and in the last trimester, as well as during nursing, 1 tablet is taken 2 times daily. Sorbifor is afforded to your patients at the pharmacies for a cost of $22.40 per tablet. Why prescribe Sorbifor? Prescribing Sorbifor, you're getting a gradual but even release of active substance for 6 to 8 hours, which facilitates comfort dosing. There's also less chance of constipation due to the slow release of ingredients, less GI irritation due to the slow release of iron, and faster absorption of iron due to vitamin C. The tablets are small, odorless, and again, very affordable. Lastly is our earwax softener called Ceramol. It is available in 2 formulations, a turpentine formulation and an olive oil formulation. The turpentine is available at $650 plus tax to your patients, and the olive oil formulation is available at $610 plus tax. Thank you very much for having me here today, and for more that Medimpex offers, you can visit our website at www.medimpexja.com. Have a wonderful evening.
I think we go on next to National Health Fund. Mr. Everton Anderson, the CEO, has he arrived yet? Okay, well,
National Health Fund has implemented a new and easier way to sign up your patients for their NHF card. If you're out of the NHF card application form, no worries. The NHF online registration system for doctors is just what you need. It's faster, effective, and convenient. To start submitting online applications, all you have to do is follow 3 easy steps. Step 1. Complete the NHF commitment form to indicate your interest in using the online system. The commitment form can be downloaded from the NHF website at www.nhf.org.jm or by contacting an NHF representative at 876-906-1106. Email your completed commitment form to customercare@nhf.org.jm. A customer service representative will verify your information and register you on the system by entering the information provided on the commitment form. Step 2. Once registered, you will receive an email with your login credentials as well as your digital signature file attachment. It's very key that your digital signature file is under your sole control at all times. Step 3. Now you're all set. You can begin submitting NHF applications online for all your new patients and medical updates for existing NHF card holders. Select the task that is applicable from the drop-down menu, select NHF card or update medical record. Under Section A, start by entering your patient name, TRN, and mobile number. Under Section C, as customary, select the appropriate illness or illnesses for your patient and add your information, including your Medical Council registration number. To complete the online application process, attach your digital signature. Remember, each time you submit an application, your digital signature is required in order to validate the submission. and to fulfill your legal obligation under the Medical Act. Your patient will receive a confirmatory SMS message indicating that their application has been submitted successfully. Signing up your patients is that simple, so register with the NHF to start submitting applications online.
The National Health Fund is committed to improving customer service through the use of technology. Doctors are key partners of the NHF, and we look forward to working with you to improve the health of clients. The NHF card application process is now easier and more convenient. The NHF, your partner for a healthier you.
ED can be incredibly frustrating, especially if you've gotten excited about pills or injections only to discover they don't work for you. Fortunately, there's another option, the AMS 700 implant. A permanent solution, the AMS 700 implant lets you feel complete and get back to spontaneous sex. It puts you in control of your sex life, enabling you to have an erection whenever you want, for as long as you want. It's completely concealed within your body, so no one will know you have it. And it's the only penile implant that maximizes your potential length, girth, and rigidity. 97% of people who get the AMS 700 implant feel satisfied with their sex life. Imagine how it could change yours. Learn more about the AMS 700 implant at edcure.org.
Free to talk about it. I feel free to know, to have it. It just lets me be me. I don't have to be afraid to say anything. If we want to tease each other in a sexual way, I feel free to do it because I can back up whatever I say. And so it brings joy. And having sex, I'm concerned about satisfying my partner. And I know that I will be able to do that. There's no ifs, ands, and buts about it. It's something that is definitely going to be done. And so to me, it's joy. Nobody knows unless you tell them. All they feel is a good, firm erection. They don't feel anything else that's connected with the implant. So everything is really natural. It feels natural. It acts natural, and it makes you think that you're natural. The only way that I know I have an implant is because it's in my mind. And when I eliminate it from my mind, I don't know the implant is there. In my everyday activities, I do not feel anything different. You can do whatever it is that you want to do, ride a bike, ride a horse. It's nothing unnatural. It's nothing different to me. And any partner that I have, it's nothing different to them because they don't know. They think I'm just natural or I'm taking the pill and that I'm able to bring enjoyment and satisfaction. For me, it was the right way to go. It was the right choice to make.
At MyTech Medical, we care about our Caribbean community health, providing the necessary information to improve its quality of life. We work closely with physicians and healthcare centers in order to keep them informed and trained on the state-of-the-art technology. No matter if your expertise is in cardiology, gastroenterology, or urology, we can provide you with the right product and the latest innovations. Safeguarding patients' welfare through the distribution of last-generation invasive and non-invasive medical equipments, improving medical procedures and treatments. Contact our Jamaica team directly. Here is their information. MyTech Medical, your trusted partner in the Caribbean.
Wow, wow. Sorry, Lisa, but I like the interview with the guy who got the implant and he felt normal and he felt good. But before you say something there, Lisa, I hope you don't mind me saying this, that there are a number of people asking about the CME credits, how much it costs, what's the bank information and so on. So Sam, can you repost that information periodically, please?
Sure.
Back to you now. Mhm.
No, it was, I think a lot of men wanted to come on just to hear that information. I think we have maxed, if you can't get in, there will be a YouTube link. So for anybody who can't get in, just click on the YouTube link. Also next, we are gonna have Mrs. Rosine Greenwood. She's our PRO who will introduce our next speaker.
Hello, everyone. Good evening. I hope you can hear me. If you can't see me, but I can see myself. Well, at this time, it gives me much pleasure to introduce to you our first speaker for the afternoon. That person is no other than Dr. Tasha Cooke. She's a consultant urologist and also a urologic, reconstruction, and incontinence specialist. Now, Dr. Cooke has been a medical practitioner for over 23 years, of which she has had more than 18 of those spent in the area of urology. Now, she graduated from the University of the West Indies here in Jamaica, where she obtained her MBBS, Bachelor's of Medicine and Bachelor of Surgery, and also later on in June of 1999, her diploma in medicine, urology specialist. Okay, she went on to do a fellowship that she successfully accomplished in 2010. This specialist as a fellowship was done in the area of urologic reconstruction and incontinence. She has held various positions as a resident urologist in Jamaica, as well as in the United States of America. Okay. She's currently working at the Cornell Regional Hospital, giving service in our specialist areas, and also in her private practice, which is in Montego Bay. Ladies and gentlemen, let's welcome just now Dr. Tasha Cooke, who is going to take us through the issues as it relates to erectile dysfunction. Okay, thank you so much, Dr. Cooke.
Dr. Cooke, you're muted. Okay, there you go. You're unmuted. Go ahead.
Okay, I'm just gonna, are you gonna allow me to share my screen?
Yeah, you can go ahead. You should see the button to share screen.
Okay. All right. It says allows, okay. Just bear with me, I'm not sure why I'm not allowing, you're not allowing me to share my screen.
It's a load. I'm not sure why it's not working. Let's do something on this side here.
Okay, Sam, while you are doing that, let's have another light-hearted moment. Is that okay, Sam? Let's have another light-hearted moment.
Sure.
Go ahead, Mag.
Thank you. This is the next one I have. Did you hear about the guy whose whole left side was cut off? Did you all hear about him? Guess what? He's all right
That's a nice one.
First the vein, in vein, and then the right cutout. That's a good one.
Yes. All right. Are you ready now? Are you ready now, Sam?
I'm totally ready. Dr. Cooke, can you tell me if you can see the share screen button on your end?
It's at the bottom of your screen, Dr. Cooke.
Okay, I am seeing it, but when I press on the share screen button, it's not allowing me to share my screen. There's an exclamation mark there. Would you be able to help me with that?
Do you have up your file? Do you have your file up on your computer? So you can
I do.
link? You do?
Yes.
Okay.
You're saying the share screen button has an exclamation sign on it?
Yes, it has an exclamation sign, like, like a
Are
warning.
you using a
sign.
Mac?
Yes.
So you probably have an exclamation sign because it's saying you don't have the security settings.
If I may interject, Sam, you were sent Dr. Cooke's presentation, so if you can share it from that end, that would be
I
good.
would rather do it from my end if that's okay. Let me just try one last time. Can I bring it on the phone? Yeah, let's bring it up on my phone for me.
Okay, I guess since we're trying to be lighthearted, I think I remember one. Two doctors went to a conference and they met each other and liked each other. One of the doctors, before sitting down to eat a snack, washed her hands. After she finished eating their drinks and snacks, she washed her hands again. They really liked each other, so they went back to the hotel together, their hotel room, of which she went in the bathroom and washed her hands again. They had some fun and she came out and washed her hands again, of which the other doctor said, "I bet you're a surgeon." And she said, "How do you know?" And he said, "Because you wash your hands a lot." And she said, "You're right." And she said to him, "I bet you're an anesthesiologist." And he went, "Why?" She goes, "Because I didn't feel anything at all."
That's good.
Oh,
good old
that
one.
one.
Good old one. Good old.
That one's good for the bar. I'm using that.
You're more than welcome, Sam.
All right, so Dr. Cooke, I didn't actually get the presentation. I did get a link to it, however, it's protected. So I would need permission to download it. Guys, thank you so much for staying with us, all 514 of you, and I think about 22 of you that's on YouTube at the moment. So,
Sam?
Yes.
Mr. Anderson is on, so if we need a little time, he could speak now.
That would be amazing.
NHF.
Mr. Anderson,
Yes.
please go ahead.
Yes, I apologize to Mr. Anderson. We found that some of the flyers went out with the 2 o'clock time instead of the 1 o'clock time. I did not realize yours was one of them. So I understand, we apologize, and that's why you're late. So we would love for you to talk now. This is Mr. Everton Anderson. He is the CEO of the National Health Fund. Welcome,
Yes.
Mr. Anderson.
Yes, good afternoon, everyone. I understand the situation. I was getting ready for 2 when I was told that you're well on the way. Nevertheless, we're here and it is my pleasure to be here. So let me recognize the Master of Ceremonies, Dr. Dawes, other members of the association, the President, Dr. William Brown. It's been a long-standing partnership between the NHF and your association, and I have to commend you for the work that you have been doing through the years. And I appear here as one person, but I guarantee you that the entire team of the NHF is fully supportive and appreciative of your efforts to make change in healthcare in Jamaica. And it's very important that we continue this important partnership. The theme this year is actually very relevant to what our focus has been over the last years. I don't know if many of you know, but this year the National Health Fund celebrates 20 years of existence. And it's been a time to rethink and to recalibrate and to look at the future. And you will note that one of the areas that have received additional benefits and coverage is the area of prostate cancer. In addition to cardiovascular illnesses, we've made quite a number of adjustments to our subsidy program in the last few months, with these adjustments slated to cost in the region of 1 billion over the next year or two. So we are on the same page as it relates to the health priorities in Jamaica. What we're hoping is that we'll deepen the partnership to ensure that especially males take a more proactive approach to protecting their health and improving their well-being, because this does have a significant impact on the social fabric, on the illness burden on families, and on productivity. And this lost productivity is really hard to regain. So as we celebrate 20 years, we're asking for not only your partnership, Dr. Brown and the team, but for the entire Jamaica, because healthcare is going to be one of those things that has to be a major governmental priority going forward. So we are going to ask for this broad partnership across government, across the health sector, including the private sector and NGOs, because similar to how people have a strong focus on earning money, a strong focus on investing, and in many cases prioritizing wealth, we believe that it is time that we prioritize health, because there can be no wealth without good health. This being said, I want to just state clearly that we will continue to support you. We will continue to work and partner with you as we work together to make Jamaica a place where health is celebrated. So I'm pleased to today declare your symposium officially open. And I again apologize for being slightly late, and we continue to wish the very best for your association as we pledge in this year to really strengthen our partnership. Best wishes to you all. Thank you very much.
Thank you very much, Mr. Anderson. Well said. Thank you very much. I think Dr. Cooke is now ready. Sam, can you share her screen?
Dr. Cooke, can you go ahead and let us know if you can share now, please?
Are you seeing my screen?
Yes.
Yes, we can
Yes,
see
we
your
are.
screen now.
All right, so you can see my screen, you can hear me well?
Yes, we can.
Yeah,
All
we
right,
can hear
first
you.
of all, I'm really sorry for the inconvenience.
No, not at all. I'm sorry that it wasn't working out, but thank you so much for being so patient and getting everything up. We look forward to your presentation.
Okay, so good evening, everybody. Good evening, viewers. I first of all would like to thank the Jamaica Midlife Health Society for inviting me to participate in the webinar this afternoon. I have no disclosures. So this afternoon, we're going to go on a little journey. We're going to start with some basics. We're going to talk about what is erectile dysfunction. We're going to look at the socioeconomical and psychological impact of erectile dysfunction, and I'll just refer to that as ED in most cases. We're going to clarify a few terms that sometimes create a little confusion. We're going to look at the types of the causes of ED, the diagnosis and can it be prevented. We're going to look at the treatment option. Is there anything new? What is penile rehabilitation? And we're going to look at the limitations, the penetration of the therapeutic options for ED in the Jamaican culture. Okay, more technologically advanced. Okay, good. All right, so I like to start my presentations with sharing with you one of the cases that I see very commonly in my clinic, like almost every week. So I have had a weak erection for almost 3 years, and it has progressively got worse. And I'm not able to achieve penetration. The medication no longer works. I'm scared to try injections. I don't wish to use the pump, which is the vacuum device. Already, I've lost 2 partners. Is there anything else I can try? And my typical response is, it appears as if the medications are not working for you. Maybe you could try surgery. That's a penile implant. And the patient usually responds in a very emphatic fashion. No, doc, it's not that bad. So what is erectile dysfunction? It's the persistent ability to attain and maintain an erection of sufficient quality to allow sexual intercourse. Although there are many validated questionnaires that are used to assess the degree of erectile dysfunction, it's primarily, for most part, a subjective complaint. I wanted to find out what was the prevalence of ED in our Jamaican population, if we had any local figures. And when I did my literature review, I only came across one article, and this was written in 2012. It was a cross-sectional study that looked at 92 patients, and they wanted to assess the prevalence and risk factors associated with erectile dysfunction in diabetic men attending a clinic in Kingston. And what they found was that ED was found in 64% of the participants. The prevalence and severity of ED increased with age for both type 1 and type 2 diabetes, from 36% in the 50 to 59-year age group to 90% in patients between 70 and 75 years old. So we can see that as you grow older, the prevalence of ED increases. On a more global level, the figures are not all that different. And if we look at the Massachusetts male aging study, they showed that 52% of the men between the ages of 40 to 70 years old experienced some degree of erectile dysfunction. That study was done quite a while ago. And at that time, there were 39 million American men affected by erectile dysfunction. And they proposed that in 2025, over 300 million men will develop ED. So what's the impact of ED? Well, there are numerous psychological and social implications of having erectile dysfunction. And as you sit there listening to me, I'm sure there are lots of things that cross your mind. Erectile dysfunction will affect a man's self-esteem. It affects his confidence and his overall quality of life. And, you know, if I just sit and think about it, when there's lack of self-esteem, lack of confidence, you may not perform that well in the workforce. You may not perform that well at your job. There are certain jobs that you may not want to attempt or to apply for. And this also will affect the remuneration you get for the types of jobs that you are willing to try. And the treatment of erectile dysfunction has improved significantly over the last 30 years. But these medications and treatment options do cost. So this is going to directly affect or impact your ability to have access to these treatment options. And of course, it's going to also negatively affect the partner's sexual function. Before we go on, let's just have a look at these terms, which are sometimes confused and we're not quite sure what exactly they mean. So impotence, erectile dysfunction, sterility, do they all mean the same thing? And the answer is no. Impotence is the inability to have an erection of the penis adequate for sexual intercourse. So this is very similar to what erectile dysfunction is. So these terms are oftentimes used interchangeably. Sterility, on the other hand, refers to the incapability of producing an offspring. You're not able to have children. So you may have a good erection, but for some reason, your sperm count is low and you're not able to have an offspring. So these terms are different. How does a man get an erection? Well, when he becomes aroused, the nerves surrounding the penis become active. The muscles around the arteries then relax and move more blood into the penis, allow more blood flow into the penis. This additional blood flow makes the penis stiff or hard, or what we call erect. The erection tightens the surrounding veins. So when the blood flows into the penis, it stays there and it doesn't flow back out of the penis immediately, thereby maintaining the erection. So on this diagram over here, we can see that there is more red or brighter red, really demonstrating the inflow of blood into the penis when the penis becomes erect. In middle age, one of the most common causes of erectile dysfunction are problems that are related to the blood vessels. And it has been shown that erectile and cardiovascular disease have a similar pathophysiological pattern or process, I should say. It has been demonstrated that erectile dysfunction precedes cardiovascular disease in most cases. This therefore provides a critical window of opportunity for clinicians to screen potential individuals with ED to identify those who may be at risk of cardiovascular disease. The time interval between erectile dysfunction and coronary artery disease symptoms is estimated to be about 2 to 3 years. The time interval between erectile dysfunction and a cardiovascular event, such as like a stroke or a heart attack, has been estimated to be 3 to 5 years. However, longer time periods have also been reported in the literature. It has also been noted that the severity of the erectile dysfunction correlates directly with the severity of the coronary artery disease. So what are the types of erectile dysfunction? Well, there are two main groups. There's the psychological group and the organic group, or the psychosocial factors and the organic factors. The psychosocial factors include things such as anxiety, depression, relationship issues, having a sedentary lifestyle, because this really predisposes you to some of the organic issues, recreational drugs, and these usually have some kind of psychological impact, and excessive alcohol use. The organic factors, on the other hand, are some of the things that we can relate to very easily that tend to happen, especially during middle age. And these are factors that affect the vascular system, hypertension, stroke, diabetes, medications, especially those used to treat psychological disorders, obesity. Obesity predisposes you to having high cholesterol. It also predisposes you to having high blood pressure, diabetes, smoking. Smoking damages the arteries, and that predisposes you to forming atherosclerosis, which is a narrowing of the vessels that I referred to earlier. Low testosterone is also another factor, and this tends to occur in middle age as well. Sickle cell disease, which is very prevalent in our population and can cause something called priapism. That's a prolonged unwanted erection that is not usually related to sexual stimulation, that basically damages the erectile function of the man. Pelvic trauma, some surgeries, especially pelvic surgery and radiation to the pelvis. I just wanted to talk a little bit about low testosterone or hypogonadism. And this usually occurs when the man produces less testosterone than normal. The decrease in testosterone may increase the risk of sexual dysfunction. It may change the body composition. They may start to put on extra weight, especially in the midsection. And there's a decline in the feeling of general well-being. They just don't feel themselves. It's been shown that 4 in 10 men over the age of 45 may have low testosterone levels, and the percentage increases with increasing age. Low testosterone has also been shown to be more common in obese persons and persons with type 2 diabetes, those that have high cholesterol and high blood pressure, and as well as high blood pressure. And typically persons complain of fatigue, loss of energy. They just don't feel themselves. Decrease in muscle strength. As I mentioned, the increase in body fat, especially around the midsection. Decrease in physical or work performance. They say can have sometimes hormonal changes that can cause hot flashes, sweats. They feel depressed, low, don't feel motivated to do stuff, lack enthusiasm, and it can also affect the concentration and memory. And of course, it reduces sex drive. It decreases your libido and can cause erectile dysfunction. I also wanted just to highlight another common area that we see in the middle age group population, and that is erectile dysfunction that occurs after prostate surgery. A lot of persons are afraid to go and have their prostates checked for the fear that they may be diagnosed with prostate cancer. But on top of that is also the fear that their erections may be affected by the treatment options available for persons that are diagnosed with prostate cancer. The concern is real because for patients that undergo surgery for prostate cancer, sometimes the nerves which run right along the prostate, are either damaged temporarily or permanently after these procedures. And of course, that can affect the erectile dysfunction. But as we go on during the presentation, we will see that there are some treatment options for persons that may have had their erections affected after these procedures. Another disease that I wanted just to highlight a little bit about is something called Peyronie's disease. A lot of persons really just don't know what this is. They may notice that after a while, the shape, the contour of the penis starts to change. And what they may be developing is something we call Peyronie's disease or penile curvature. It's due to a fibrous scar forming inside the penis, and that is what causes the penis to be bent, and it is more prominent when the penis becomes erect. It can be quite painful, and the curvature of the penis may actually be so severe that it affects the ability to achieve penetration. So the approach to management of these patients will include correcting any factors, correcting any contributing factors. And those are some of the things that we identified were the predisposing factors on the previous slides. And also just generally, just to recommend a healthy lifestyle. And everybody hears that term being used frequently, but what really is a healthy lifestyle? And I mean, you know what it is. There are, you know, the general guidelines addressing factors with your diet, exercise, and just, you know, trying to make sure that you check to make sure everything is, there's nothing out of range, for example, that can be corrected. Because as we have seen, the causes of erectile dysfunction are actually multifactorial. If there are any psychosocial factors that have been identified, then they may seek to see a therapist or to undergo some counseling. And we usually start with the least invasive therapist first, and then move on to more invasive options. Depending on the underlying problems, there are some persons who may need to have a specialist consultation, and high on the list is going to be a cardiologist. So with evaluation of these patients, we want to look at their medical history, their sexual history, and to find out if there are any psychosocial factors. These patients are examined in the standard fashion to see if there are any abnormalities that can be detected and corrected. And we may even see some abnormalities that might give us an insight as to the underlying problem. And there's some specific lab work or investigations that your doctor may ask you to do. Over the last 30 years, there have been some novel effective treatments for the treatment of erectile dysfunction. And high on the list are the phosphodiesterase type 5 inhibitors, the PD5 inhibitors. Also, intracavernosal injections have also been used. There's a vacuum device, and when these conservative treatments, either the PD5 inhibitors, intracavernosal injections, or the vacuum device are not beneficial, they don't work, then there's always the option of putting in a penile implant. So the oral medications are things that you probably are quite familiar with. You'll see the ads on TV, or you'll hear conversations in everyday life talking about these medications. And really what they do is that they improve the blood flow into the penis. This was the same when I had the slides earlier showing you what happens when there is arousal, there's increased blood flow into the penis. So when the vessels become narrow, then these medications are used to improve the blood flow into the penis. And it's interesting because the penile arteries are very small. The heart arteries, the cardiovascular arteries are even, the coronary arteries, I should say, are even larger than the penile arteries. So we can understand that when the penile arteries become blocked or narrowed, the symptoms occur earlier than when the coronary arteries become blocked. And so these medications are typically taken about 30 to 60 minutes before planned intercourse. They tend generally to be quite successful. However, there are some side effects, and a lot of patients may or may not be able to tolerate these side effects. And they include muscle aches. I typically describe this to my patients as, you know, they feel as if they've just started going back to the gym or exercising after having not done this for a long time. They can get headaches, visual disturbances, and just facial flushing, looking a little rosy or red. If you're on nitrates or you put any medication under your tongue, this medication is not for you and you should not have it. What are the intracavernosal injections? Well, these are injections in which the medication, special medication, is injected into the penis. We will show the patients how to do it, and this is something you will do at home by yourself once you understand how to do it. And it's very similar to patients that have to give themselves insulin. Use a very tiny needle and you pull up the medication, you inject it into the penis, and the onset is anywhere between 5 and 20 minutes if it's effective. They work well for a number of patients. However, some patients just don't like injecting themselves. And even although the medications work well, a lot of patients don't continue to use it on the long term. The side effects of the medication include pain, penile pain, hardness at the site at which you give the injections, and you may get like a little hematoma or a swelling at the site at which you get the injection. With these medications, both the intracavernosal injections as well as the oral tablets that are used to enhance erections, if you have a prolonged erection, you definitely will need to call your doctor or go to the nearest hospital for advice and treatment. Urethral suppository. In some cases, we can actually put a little tablet inside the urethra. It has a fairly quick onset of action, and for a lot of patients, it's quite successful. However, these medications can also cause pain in the urethra, pain in the penis and testes, can also cause low blood pressure and dizziness. And sometimes these are the reasons, and these include the reasons for which it is discontinued. It's not used long-term. Unfortunately, urethral suppositories are not available locally, so this is something that would need to be sourced overseas. Another option is the vacuum device. This is a small device or a hollow tube that's placed over the penis. The pump is used to create a vacuum or a negative pressure. And once this is achieved, blood is sucked or pulled into the penis. And then a plastic ring is placed at the base of the penis. And this is done to prevent the blood flowing back out of the penis. The satisfaction rate for this procedure varies from 60 to 80%. Importantly, this is usually recommended for persons that have like stable partners. The partner fully is quite aware that the man has some degree of erectile dysfunction, because it takes a little bit of the spontaneity of sexual intercourse. So because of that, some patients don't like it, and so it's not the dropout rate or the discontinuation rate tends to be high. So when those conservative therapies fail, then you may move on to more invasive therapies or to the surgical options. And this includes putting in a penile prosthesis or a penile implant. So it's really for patients who are refractory, or the oral tablets don't work for them. The vacuum device is not beneficial. The intracavernosal injections or the injections don't work for them, or they don't like it, or they can't tolerate it. If they have Peyronie's disease associated with erectile dysfunction, and because Peyronie's disease in severe cases usually requires surgical correction. If you have priapism, which is the disorder that occurs in sicklers or sickle cell disease, and more recently in transgender procedures. So a penile prosthesis is an external or implanted device that substitutes the function of the erectile bodies to achieve penile rigidity, thus maintaining an erection. For a very long time, they've been trying to find material that could be useful for creating a penile prosthesis. And this really, in the literature, it's dated as far back as 1936. And Bogaraz actually used rib cartilage to create the first penile prosthesis. The rib cartilage became infected and it bent, and it just wasn't very successful. And since then they've been trying. Well, Scott and his colleagues in 1973 invented the first inflatable penile prosthesis. And it really provides the background for which the modern day inflatable penile prosthesis is based. There are two main ones. There's one from AMS and there's one from Coloplast. Around about the same time in 1974, Small and Carrion, they also invented something that was similar, but this device just included two rods, was made up of two rods, which were able to bend. And this really provides the basis for the modern day malleable device that we use. So the malleable device is really simple to use. It's great for patients that have poor manual dexterity, that their fingers, they're not so good with their fingers for whatever reason. They may have arthritis, they may have had a stroke, but there's no change in the rigidity of the rods. In other words, the rods don't get soft and then get hard. They're the same, and basically they're just bent to conceal them. And when you're ready to have intercourse, the rods are straightened, very much like in the picture here. It's a good option for men that are willing to forego the cosmesis of the inflatable device. It has a very low mechanical failure, but because the rods are always erect, then there's always a possibility of erosion. Even although it's small, I still have to share that with you. The inflatable device is one that most closely resembles the normal physiological erection. This one, however, requires good manual dexterity. When the penis is flaccid, it may be concealed, so nobody will know that you have the device. It consists of a pair of cylinders, and these are implanted into the penis. The pump is placed in the scrotum, and this is a reservoir that's placed in the lower part of the abdomen. And this is it's really placed with a very small incision, and there are different ways that we can put it in. You can get a very small incision above or just at the lower part of the abdomen or the belly. There's an approach where we can do it through the scrotum. And in these cases where there are other conditions such as Peyronie's disease, then we use a degloving incision to put in the prosthesis. So it's a very small incision, and all the components are hidden. So we're going to just look at this small video from Boston Scientific, which shows where the rods are placed in the penis. When the man is ready to have intercourse, he squeezes on the pump, and the fluid is transferred from the reservoir into the pump. And when he's finished, he presses on the pump in another direction, and then the penis goes down or attains a flaccid state. And these are some pictures to show. This is immediately after the surgery. And this is 3 months after surgery. So you can see that, for all intents and purposes, I'm not able to see any rods or anything in this penis. I'm not even able to see the pump, so it is well concealed. Nobody would know. And this is with the penis elevated. Right here, you can see the impression of the pump. So I mean, somebody really has to have a trained eye, or you would actually have to feel the scrotum to be able to detect any of the parts. But for the most part, everything is concealed, and you would not be able to know that this person has a penile prosthesis. So the penile implant is really designed to be a permanent solution to erectile dysfunction. It allows spontaneity. Erections last for as long as you want. If you want to have intercourse for 10 hours, 2 hours, half an hour, it doesn't matter. When you're finished, you then press the pump and deflate the device. Or if you have the malleable, you just bend the device to conceal it in your underwear. It does not affect ejaculation. It doesn't affect orgasm. It doesn't affect the sensation. So just like in the video at the beginning of the seminar, where the person said that, they were fine, they felt just normal after having the penile implant put in, it is absolutely true. And most importantly, there's a high patient satisfaction. So these were just some studies to show that the device is durable, because a lot of patients always ask me, how long does it last? Well, in some of the more robust studies, they saw that over 97% of the patients had their implant at 3 years, 93% at 5 years, and 78% of them had it at 10 years. And typically, the manufacturers of the device recommend or state that the device lasts about 10 years. After that, if you have mechanical dysfunction and you need to replace it, then that can be done. Another question that I'm always asked is, how safe is the device? Well, it's pretty safe. And in this study that looked at the safety and efficacy of the device, 86% of the patients had erections that were suitable for sexual intercourse. Sorry, 87% of the patients still, 86% of the patients still had the device, and 87 of that 86% of the patients had erections that were suitable for sexual intercourse. And I added this here, that over 88% of the patients would recommend the procedure to someone else. So this shows that there is high patient satisfaction. 97% of them would recommend the implant to others. 98% reported that their erections were excellent or satisfactory, and 96% of the patients reported sexual activity with the implant to be excellent or satisfactory. So overall, there's good satisfaction rates. There are good satisfaction rates. The complications are relatively low, and with improvement in technology, the complication rates have really come down. The biggest one really is infection of the implant, because should the implant become infected, it will have to be removed. And that's really the big one. Thankfully, those cases are very low, or a very small percentage. So the penile prosthesis is reliable, it works well, it's safe, and has low complication rates. And I like to refer to this option as one that restores the whole man. And this was a term used by one of my mentors, Professor Burnett. But what are the challenges to accepting this? Because if you remember from the case, even although our patient had erectile dysfunction, the medications weren't working well, he did not want to try the injections, and he did not want to try the vacuum device, he was still so unwilling to entertain the option of surgical treatment. Well, the cost of the device, it's expensive. There's no doubt about that. The inflatable device is probably about $13,000. It's estimated approximately $13,000 US dollars for the device alone. And the malleable device is about a third of the cost of the inflatable device. It works well. It's still a good option. And that's definitely something that could be considered. The other challenge is that our healthcare providers don't know about these options. So it's going to take a bit of education so that they can become familiar with the treatment options, and then they can share the treatment options with their patients. And these are doctors, nurses, community health aides, just, whichever section they fall under the healthcare provider. Patients are really scared of surgery, but thankfully this procedure has a very low complication rate and a very high success. So again, with education, we'll be able to explain to patients that, we start with the least invasive options first, which are the medications or the injections or the device. But when those don't work, then you move on to the next step. And changing the perception. Patients will have erectile dysfunction. They don't understand that this is a disease just like having high blood pressure or diabetes that may require medication to have it controlled. We will also need medication for the control of erectile dysfunction. And just like with diabetes or hypertension, sometimes the medications don't work and we need to move on to other things. Similarly, with erectile dysfunction. And hopefully, with education, the health insurance companies will provide more support for these treatment options for erectile dysfunction. For completion, I have added a slide that highlights some of the experimental options. As I said, they're experimental. And most of these therapies, which include shockwave therapy, platelet-rich plasma, or penile ultrasound, those therapies really are aimed at improving the blood supply to the penis and thereby trying to improve the erections. What is penile rehabilitation? Well, penile rehabilitation involves the use of measures to prevent erectile dysfunction.
Dr. Cooke, can you, time is running out, so can you try to wrap up soon, please?
I just have about a few more slides. Thank you. From becoming chronic once it has occurred or being diagnosed after a critical episode. This concept was popularized after radical prostatectomies. And it involves all the things that we have listed before, correcting the psychosocial factors, using the conservative treatments, and if those don't work, then going on to surgical treatment. So in conclusion, erectile dysfunction is a problem that may be associated with other conditions, and so they should seek help early. There are a variety of treatment options, but sometimes compliance is poor. Patients don't stay on the medication long term. A penile prosthesis is a reliable, effective option for treating patients with ED who have failed conservative therapy, thereby restoring confidence and normal function. Penile prosthesis can provide a permanent solution to erectile dysfunction. We will need to educate our healthcare providers so that they will feel comfortable sharing this option with patients. Although costly, the satisfaction rate for penile prosthesis is very high. And I will end with a quote from one of my patients. Doc, this is the best investment I've made in myself. Thank you.
Thank you very, very much, Dr. Cooke. That's actually a great presentation, quite detailed. We are running a little late, but I did want to take a few questions and answers. A few questions with your answers. I think one question, Sam, you want to read this one or you want me to, or Magna?
So the question that's in the Q&A is actually about payments for CMEs.
No, not that one.
Which one?
There's one in the question that says, not understanding how ejaculation is possible with the manufactured erection. Please explain.
Okay, so with the penile prosthesis, that device is placed in the penis so that the penis can become erect. The sensation, the arousal, the sensation is the same, just like before. So if the man was able to achieve ejaculation before the erection, before he had loss of erections, then he will be able to do it afterwards. It's really just allowing the penis to become erect. So ejaculation is definitely possible.
And another question was, can quadriplegics use any of these devices? Which is yes, but go ahead.
Yes, so the answer is yes, right? For a quadriplegic, right, the concern would be how they manage their bladder, because if they're gonna have a catheter in, then that would be an issue. So we would have to coordinate how they manage their bladder with the device in, because you don't really want to have anything that's going to potentially create a risk of erosion of the device or damage to the urethra, which could potentially cause an infection and damage the device.
Any of the panelists have any other questions?
Well, I have
saw some
one
movements like yes.
I have one comment that everybody, including myself, Dr. Tasha, is saying, excellent presentation. I didn't know that the penis had so much to present on it. I have never heard such a detailed presentation.
Very detailed.
On erectile dysfunction. And I really enjoyed your presentation. And for those of you who are saying how it was excellent, please put a nice, what do you call this thing again? What do you call it again? And you sent in the chat where you see all the balloons going up.
Emoji.
Emoji, yes. Please put it in the chat and let Dr. Cooke see it. Excellent presentation, excellent.
Thank you.
Yes, I see where Nicolene, oh, see they're going up, Dr. Cooke, so you know they're really looking good. And before you go into can I say another comment, another joke before we go into the next one?
No, I think Dr. Koren wanted to say something, Magdalena.
Okay, go ahead, Dr.
No, I want to hear your joke.
I see you've been enjoying them, right? Okay, patient to doctor. And I thought this was appropriate after Dr. Tasha's presentation. Patient to doctor. I've swallowed a spoon. Doctor to patient. Sit down and don't stir.
I like that one too.
You're doing very well, Magdalena. Love it.
Thank you. Okay, over to Dr. Koren.
There's another question. I think someone is asking about urination. Do you see it, Sam?
I'm sorry, no, I think I missed that one. What was it?
They said there's a question about urination in the Q&A, but I'm not seeing it. So I was hoping you did.
Sure, there's an anonymous question. What about urination? Is it affected in the presence of the implant?
Dr. Cooke? Yes.
To that question, there's a question that says, the penis is smaller when flaccid. How does it enhance the length and girth of the penis?
Right.
So really, we tell patients that the length of the penis after the implant is typically the stretched penile length. However, the devices do increase with only the inflatable device, not the malleable. The inflatable device may increase a little bit in length and a little bit in girth. So that is how the penis can become longer and have a wider with the penile implant. But as a general rule, we tell patients that the penis is the stretched penile length. I'm hoping that answered the question.
There is another question. What is penile angulation?
Penile angulation or penile curvature is usually the term that that usually refers to patients that have Peyronie's disease, which I alluded to earlier in the presentation. And that's because of scar tissue forming on the penis and causes it to bend. Sometimes when it's flaccid, but it's more prominent when the penis is erect. So typically you don't see the penis when it's bend in the penis when it's not erect, but when the man gets an erection, that's when you see the curvature or the bend in the penis.
Okay, thanks again.
Right. And I
Dr.
think the
Cooke,
final
excellent
question-
detail, great drawings and what's now available. So I'm sure you will get a lot more referrals and questions from this. Over to you, Magdalena.
Yes, I think Sam was trying to say something just now. Sam?
No, it was about the urination question, but I think in the interest of time, we should move on. Wonderful presentation.
Okay.
Thank you.
You're welcome. Very, very good. I mean, I think you need to have a group of women understanding what it is for a man to have that procedure. Back to you, Dr. Lisa.
Oh, I was saying you can, next is our sponsors, which the first one is Abbott.
Over to you, Sam.
Take a powerful step in building new tissue with Juven. Juven is a refreshing therapeutic nutrition drink that has been clinically shown to support wound healing in as little as 2 weeks. Taking just 2 packets of Juven per day has been clinically shown to help your body repair after injury, surgery, and wounds. Juven is formulated with powerful ingredients: arginine, glutamine, beta-hydroxy-beta-methylbutyrate, HMB, collagen protein, and micronutrients. These ingredients work together to support building tissue. Arginine is an amino acid that helps promote blood flow in the body. Increased blood flow improves delivery of oxygen and nutrients, both vital for wound healing. Arginine also promotes building of proteins that can contribute new tissue to support healing. Glutamine, also an amino acid, plays a role in collagen production and supports the immune system. HMB helps protect proteins from breaking down in your body, which helps new tissue to build up. Collagen is a protein found naturally in bones, connective tissue, and skin. Ingestion of hydrolyzed collagen affects the skin and stimulates internal collagen production. Hydrolyzed collagen has been shown to increase the rate of wound healing. Antioxidants, vitamin C and E, vitamin B12, and zinc are micronutrients which have been shown to be important in the wound healing process. Taking just 2 packets of Juven per day has been clinically shown to support wound healing in as little as 2 weeks. For more information on nutrition and wound healing and Juven, visit juven.com today.
Good day, everyone. I am Debian Coulimore from MSN, and today I would like to talk to you about Silorel. This slide shows you what a normal prostate looks like to the left of the screen, hence a happy face. Now to the right, it shows an enlarged prostate, hence a sad face. An enlarged prostate will cause constriction of the urethra, causing uncomfortable urinary symptoms. Now, what is Silorel and its indications? Silorel contains the active ingredient silodosin, and it is an alpha-1 adrenoreceptor antagonist with high uroselectivity. It is indicated for the treatment of the signs and symptoms of benign prostatic hyperplasia, also known as BPH, and for medical expulsion of distal ureteric stones. How does Silorel work? Well, it works by binding to alpha-1A adrenergic receptors to induce prostatic and ureteral smooth muscle relaxation to improve voiding symptoms. It also works to target afferent nerves in the bladder to reduce bladder overactivity and storage symptoms. Silorel is US FDA approved for treating BPH. It is 50 to 100 times more selective compared to other alpha blockers. It has higher efficacy and fewer cardiovascular adverse effects. It improves overactivity and obstruction grade in patients with BPH, and it effectively manages lower urinary tract symptom for more than a year in at least 44% of patients. Now, let's look at the side effect profile of the alpha blockers. As you can see from a quick glance, based on the color scales to your right, silodosin is the best. Silodosin offers clinically significant benefits in patients with lower urinary tract symptom or BPH who were not satisfied in previous treatments with other alpha blockers. Looking at the graph, there were less adverse events of dizziness, gastrointestinal system issues, headache, rhinitis. There was no erectile dysfunction. In comparison to tamsulosin, there was less events of postural symptomatic hypertension, and there was no sinuscope symptomatic hypertension. Selectivity. As you can see from this slide, prazosin, doxazosin, terazosin, and aflozosin are non-selective alpha-1 adrenergic receptor blockers. Of the selective groups are tamsulosin and silodosin. Silodosin, however, carries the highest selectivity for alpha-1A. Let's look at the long-term benefits of silodosin in lower urinary tract syndrome and benign prostatic hyperplasia. Based on a study done by Yamanishi T et al., they evaluated the long-term efficacy of silodosin on 75 male patients with lower urinary tract syndrome and benign prostatic hyperplasia, ages 50 to 93 years old, who were treated with silodosin 8 milligrams daily up to 4 years. This study showed that the mean total international prostate symptom score, the total storage symptom subscores, the total voiding symptom subscores, the post-micturition score, and the quality of life score decreased significantly, all with a p-value of less than 0.001 at 1 month after the treatment, and it remained stable up to 48 months. It also showed that Qmax increased significantly with a p-value of less than or equal to 0.001, and PVR, which is a post-void residual value, it decreased significantly with a p-value equaling 0.003 at 1 month after the therapy, and these changes were sustained for up to 4 years. In conclusion, you can say silodosin appears to be effective and safe for long-term in patients with lower urinary tract symptoms and benign prostatic hyperplasia. Silorel provides improvement in storage. There is a less frequency, less urgency, and less nocturia. It also provides improvement in voiding. So there's less strain to void, less weak stream, intermittency, and less incomplete emptying. Pharmacokinetics of silodosin shows that maximum concentration is reached at 61.6 plus or minus 27.54 nanograms per ml, and the time to reach maximum concentration only takes 2.6 plus or minus 0.9 hours, and the elimination half-life is 13.3 plus or minus 8.07 hours. Silodosin is metabolized by the cytochrome 450 system, and it is excreted in the urine at 33.5% and 54.9% via the feces. Dosing. Silorel 8 mg is to be prescribed once daily and is to be taken with a meal. It will provide symptomatic relief of BPH in men and also used to treat medical expulsion therapy of urethral stones in males and females. Silorel 4 mg should also be prescribed once daily and taken with a meal to provide the symptomatic relief of BPH in men who are mild to moderate renally impaired, whose creatinine clearance value is between 30 to 50 mils per minute. It may also be used to treat medical expulsion therapy of urethral stones in both males and females who are also renally impaired. Patients who have difficulty swallowing may open the capsule and sprinkle the powder on a tablespoonful of applesauce. The applesauce should not be hot and should be soft enough to be swallowed within 5 minutes without chewing, and followed with an 8 ounce of cool water. Silorel is subsidized by NHF for BPH, and so for the 8 mg dose, your patients will pay about $97 per tablet or $2,910 for a month's supply. For the 4 mg dose, your patients will pay around $128 per tablet or $3,840 for a month's supply. Please also note that Silorel is covered with private health insurance and so can cost your patients less than $1,000 if both insurance are used. Silmelt. Silmelt contains the active ingredient sildenafil citrate at 50 milligrams. It is a fruit-flavored, mouth-dissolving tablet that is used to treat erectile dysfunction. Silmelt significantly improves penetration and erection maintenance. It achieves erection hard enough for successful intercourse. It increases intercourse satisfaction, improves quality of life of both patient and partner, and it also provides a quick onset of action as it enters the bloodstream faster via the salivary gland. Silmelt, hardness that melts her. Thank you.
Wow, again. Woo! What a day of learning for everybody. So is there another presentation, Sam? Or should I do my moment of laughter while we wait?
You can do a moment of laughter.
Okay, let's do another moment of laughter. A friend failed his medical exam when he x-rayed his lower torso. He didn't put his heart into it.
You're the best, Magdalena.
Thank you. At least I made Dr. Michael and others laugh, and you as well, Morsi. Okay, Sam, over to you. Next.
Thank you,
I
Doc.
think
So there were two
weren't those both
presentations.
presentations,
It
Sam?
was MSN and it was Abbott. Both were done. I know that Paul from Abbott apologizes for having some internet issues. Once he's free, he'd love to join again later just to share some more products with us. So I think we'd now hand over to Dr. Kervin Dawes, who will introduce our next speaker.
Okay, so the next speaker is Dr. Michael Koren, who has spoken for us, one of my best friends. He is him to send me a CV. His assistant sent me a 35-page CV. So I said, okay, I'm just gonna speak on what I know about him. Because he is very accomplished. He's a graduate of Harvard, went to Harvard and MIT, where he has his MD degree. He's, for us in the English side, he's a consultant in cardiology. He is the CEO of Encore Research Company. He is also has done many, he has published several papers, I think over 100 when I was glancing through. He's the founder of Ask 1000 Doctors, which is a physician online consultation system. He's the founder and director of the annual CME course, Clinical Research Training for Physicians. And he's the founder and director of Jacksonville Center for Clinical Research. He definitely is very qualified to give us this next one. He's also one of my best friends, loves golf, loves his kids, loves travel, and has a lot of special interests. He also is a musician. Plays the piano very well and was part of a band and still does that sometimes. Very talented. And I'm gonna just turn over to Dr. Michael Koren.
Well, thank you very much for that wonderful introduction, Lisa. And I'm going to pull up my slides here and hope that everybody can see them. Can we see them and hear me okay?
Yes, sir, we can.
Okay, fabulous. So before I jump into my prepared comments, I have to follow Magdalena's lead and do a little laugh and learn. And based on what I've heard so far, I have a wonderful story that actually fits in beautifully with the theme of the presentations today. And it involves a fellow who is very proud of the fact that he looked much younger than his actual age. And this fellow had this interesting routine. He would get up in the morning and he would go to Starbucks and get a chai tea at Starbucks. And on this particular day, he was online waiting for his chai tea. And he turned to somebody who was online with him. And he said, "How old do you think I am?" And the person looked at him, looked him up, down, and says, "Well, I don't know, you look like you're about 40 years old." And the fellow says, "No, I'm actually 65 years of age." And the fellow said, "Wow, you look much younger than you are." So he gets his chai tea and then he goes to the local newsstand. And while waiting for the newspaper, he turns to somebody next to him and he says, "How old do you think I am?" And the person looks at him and says, "Oh, you look like you're about 45 years old." And the fellow says, "I'm actually 65 years of age." And the guy says, "Wow, you're much younger. You look much younger than you are." So he takes his tea and he takes his newspaper and he goes to the park and he sits at a bench, and a woman who happens to be part of the Jamaican midlife group sits next to him. And so she sits next to him, and he turns to him and he says, "How old do you think I am?" And she says to him, let me put my hand in your pants and I'll come up with the answer." So she puts her hand in his pants and starts feeling around a little bit. And she takes her hand out and she says, "You are 65 years of age." And the fellow, shocked, he said, "Oh my God, no one ever gets my age right. How'd you do it?" And she says, "I was standing in line behind you at Starbucks."
Okay, Dr. Koren, very good.
So one of my favorite stories, very apropos to this audience. So good afternoon, everybody. It's really my privilege to be addressing such a wonderful group of people, and a real pleasure to connect with my friends from Jamaica. So this is a lot of fun for me, and hopefully you'll indulge me for about 20 minutes. I'm going to talk about something that's actually a pretty interesting combination. Dr. Lisa Kirvan-Dawes approached me a few months ago and said, "Would you be willing to talk about cardiovascular disease in a conference that's also addressing prostate cancer?" And I thought about that and I said, wow, there's actually a pretty interesting connection between those things. So that might be a fun thing to talk about. So let's jump into that. So this is a CME program, so my disclosures are listed here. I would say that everybody should know that I do run clinical trials for a living. I am an independent person when I run the clinical trials, but we work with a lot of different pharmaceutical companies. And my company also owns this MedEvidence platform, which is an educational platform that we use to educate patients and physicians. And this presentation, which I'm giving today, is part of that platform. So our learning objectives for today are as listed here. We're going to talk about the concept of cardiac risk factors, both modifiable and non-modifiable risk factors. We're also going to talk about the prognosis of prostate cancer survivors, and also talk about, more in general, about the prognosis of healthy men and women in their 60s. And then I'm going to jump into the ABCDE approach to reduce cardiovascular disease, which is a way of looking at a particular patient and going through a checklist of things in order to determine what you can do for that particular person. So this gets into my outline in a little bit more detail, and you can take a second to look at that and read that. And let's jump in. So first, let's define cardiovascular disease. Cardiovascular disease is the general term that we use to describe the disorders that affect the heart or blood vessels. And one of the interesting parts of cardiovascular disease is that the likelihood of having this problem is highly predicted based on certain risk factors. So if you're a lucky person that has no risk factors, your risk of cardiovascular disease is quite low. But if you're less fortunate and you have multiple risk factors, your risk of cardiovascular disease is far greater. The other thing about cardiovascular disease is that it comes down to very specific complications, most of which you'll be familiar with. So for example, when you have the situation where there's a sudden loss of blood flow to the heart or brain or body part due to a blood clot, we call that thrombosis. If you have a fatty deposit inside of an artery, which reduces blood flow, and that can happen in the penis, as we just learned about from Dr. Cooke, or can happen in other vessels, for example, the heart arteries, and cause angina. This is the process of atherosclerosis that can cause multiple symptoms in people. The heart muscle can also enlarge, sometimes due to high blood pressure, sometimes due to valvular heart disease, and or weaken. And this can cause the clinical problem of congestive heart failure. And finally, blood vessels can enlarge and even burst when they get large enough or get weak enough. And we call this process an aneurysm formation. And certainly that's a potential devastating complication of cardiovascular disease. So again, I mentioned these clinical events, and I want to define them for people. I know we have both people in the healthcare world and people who may not be in the healthcare world. So I want to make sure that we're on the same page in terms of terminology. So some of the words that we use would be a heart attack, which again is a clot to the coronary artery that damages the heart muscle. We also call this a myocardial infarction. We can have a stroke, which is a similar situation where there's either an emboli or a piece of clot that goes to the brain, or a thrombosis of an artery that affects the brain, and this is called a stroke. You can have peripheral arterial disease, which can affect often the lower part of the body, cause pain in the legs when you walk, for example, which is called claudication, or cause erectile dysfunction. We have congestive heart failure that I alluded to before, which is when your heart cannot pump strongly enough to meet the needs of the body. And people typically get shortness of breath and swelling when they have that particular condition. Chronic angina is a situation where your heart arteries can't provide enough blood and oxygen to the heart, and people typically will have some sort of chest discomfort or sensations that are triggered by the fact that they're either stressed or they're doing some activity that they really just quite can't handle. And finally, we have valvular heart disease, when the valves that separate the chambers of the heart are failing. Either they get leaky or they become stenotic or hard. In that case, your heart is not functioning at its maximal capability. And this again results in symptoms of perhaps chest pain, perhaps shortness of breath, and feeling poorly. There are certain conditions in cardiovascular disease that seem to disproportionately affect Black patients. And the one that we talk about most commonly is stroke. Black patients seem to be more likely to develop strokes, and this is largely a consequence of a higher incidence of hypertension. But there are actually some things that Black patients are less likely to suffer from. So the classic example of that is called aortic stenosis, which is a hardening of the aortic valve, which can lead to complications. And for reasons we really don't understand, Black patients are less likely to have that particular problem. The other thing, as I mentioned to you, is that these risk factors predispose patients to heart disease, and some of them we can change, and we call those modifiable, whereas others we cannot change. And the ones that we cannot change, we call not modifiable or unmodifiable. So let's jump into these risk factors a little bit more. So for example, here, we see that smoking and vaping is certainly a modifiable risk factor. That's something that is hard for some people to get over, but certainly the ingestion of tobacco through smoking or vaping is something that has very deleterious effects to the arteries and the heart. And this is something that we can certainly work with people to try to avoid that exposure. High blood cholesterol or hypercholesterolemia is also a very, very common problem. This is in some patients a genetic issue because they have genes that lead to extremely high levels of either cholesterol or triglycerides. But in many cases, it's a question of diet that isn't optimized or other risk factors such as being sedentary. High blood pressure, as I mentioned previously, is elevations in your blood pressure that can lead to heart attacks or strokes. And this problem, when you have high blood pressure over extended periods of time, has this pernicious effect of making the blood vessels less pliant, makes them harder. And the more blood pressure problems you have, the more likely you are to have a continuation of that problem and a worsening of that problem over time. Then we have diabetes, which is high blood sugar. It's associated with being overweight. We have a lot of ways of treating this, but certainly the effects of diabetes can be quite devastating, and they include both cardiac and non-cardiac issues. So from a cardiologist's perspective, folks with diabetes are more likely to get heart disease. They're more likely to have peripheral arterial disease, and their blood vessels will become less pliant and less able to react normally. Again, that can lead to erectile dysfunction, as mentioned previously. Physical inactivity is an important risk factor that's completely modifiable. It's not easy to get into an exercise routine for many people, but certainly once people are able to do that, they will benefit from that. And I mentioned obesity, and obesity in of itself is not considered a risk factor, but it leads to other risk factors, as you can see above. So obese patients are more likely to be diabetic. Obese patients are more likely to be inactive. Obese patients are more likely to have high blood pressure and high cholesterol. So you can see that it has secondary effects that are important and certainly can be modifiable. Then there are the non-modifiable risks. So I like to remind my patients that it would be wonderful if we can choose our parents, but we really can't. So the genes that we get from our parents and our heredity is something that we can control. We just need to do the best we can to deal with the hand that we've dealt. And in many cases, we have wonderful therapies and ways of overcoming even a very, very strong family history of early coronary disease. Age is another one of those non-modifiable risk factors. And the older we get, the more likely we are to have cardiac and vascular complications. But there's a bit of a silver lining to that, which I'll mention in a moment. Genetic sex is associated with higher risk, that is male sex. So men are known to develop coronary artery disease and other vascular complications about 10 years earlier than women for reasons that I'll get into momentarily. And finally, you may not think about this, but your geography and the weather can actually be a non-modifiable risk factor. So it's been shown, for example, that in the setting of waiting for a hurricane to hit your island, people are more likely to develop medical complications, including heart attacks and strokes, or people are more likely to have complications that affect their health after a geological event such as an earthquake. And certainly we don't have control over those things. So I mentioned this connection between prostate cancer and cardiovascular disease. I'm going to show you some of the statistics on that. So prostate cancer is the most common cancer in American men. I think that's also true for folks in the Caribbean. In 2023, the American Cancer Society estimates that there are 288,000 new cases of prostate cancer every year and about 34,000 deaths that occur yearly. Interestingly, the policies of the government in our institutions can actually influence these diagnoses. So back in 2007, there was a change in PSA screening recommendations that were adopted by a lot of primary care physicians in the United States. And with that change, we were less likely to find prostate cancer in its early stage. So we actually saw a drop in the diagnosis. But unfortunately, that just seemed to delay things. And then we sort of loosened this back up again in 2004, and we found that there was now a greater incidence of these problems being discovered on a yearly basis. And unfortunately, an even greater likelihood of finding advanced stage disease, in part because we weren't searching for it at the earlier stages. So again, I think this makes the point that early diagnosis has a number of different benefits, and you don't have to deal with the later complications of any particular problem. And to put this in perspective, 1 man in 8 will receive the diagnosis of prostate cancer during his lifetime. So let's jump into some of the prostate cancer statistics and risk factors, which also turn out to be cardiovascular risk factors. So age is by far the strongest predictor of prostate cancer risk, and 6 in 10 cases occur in men greater than 65 years of age, with the mean age of diagnosis of 66 years. Similarly, cardiovascular disease and stroke also is much more likely as we get older. Most men diagnosed with prostate cancer actually don't die from prostate cancer, which is a really, really interesting part of this disease. In fact, there are 3.1 million US men who are diagnosed with prostate cancer who are alive, and many of them are very active, and many of them have relatively normal lives and have overcome the diagnosis and the initial treatments. There's a higher prevalence in African-American Caribbean men of African ancestry than other races, with an actually earlier onset of prostate cancer compared to other populations. And it's really unclear why these geographic, racial, and ethnic differences exist. But this is probably the most important point I'm going to make, which is that the risk factors for prostate cancer are also the risk factors for cardiovascular disease. And studies have shown that patients with prostate cancer are much, much more likely to die of cardiovascular disease than the direct complications of prostate cancer, which is why cardiologists are very interested in this condition. So let me share with you a few high cardiovascular risk profiles. Here you see that if you have a family history of early atherosclerotic cardiovascular disease complications, we typically say if you have people in your family where the men developed cardiovascular disease before the age of 55 or women before the age of 65, chances are you have a strong genetic predisposition to cardiovascular disease. And you should certainly consult with your physician about looking at things such as genetic dyslipidemias or high cholesterol levels that are genetically determined. Or you may have the type of issues with your kidneys or your blood pressure that would predispose you to earlier onset of cerebrovascular disease or stroke. High serum cholesterol, either by genetics, by virtue of poor diet or inactivity, or based on what we call polygenic elevations of cholesterol, meaning lots of genes are involved, is a very important and very modifiable risk factor for cardiovascular disease. So we consider somebody that has an LDL cholesterol of greater than 100 milligrams per deciliter or greater than 2.8 millimoles per liter as having hypercholesterolemia. Another metric that we use is called non-HDL cholesterol of greater than 160 milligrams per deciliter. And this measurement also considers triglycerides in assessing the cardiovascular risk of our patients. Patients that have metabolic syndrome are at very, very high risk of cardiovascular disease. And this is the typical person who's a bit overweight, has central obesity, a big gut, if you will, and maybe has a bit of an elevated cholesterol and doesn't do that much day to day in terms of physical activity. We know that this particular population is at quite high risk for cardiovascular disease. Chronic kidney disease is a risk factor for cardiovascular disease, as is chronic inflammatory conditions such as HIV/AIDS, rheumatoid arthritis, or anything that results in your CRP or C-reactive protein being elevated in your blood system for extended periods of time, which covers many, many different inflammatory conditions. And then, as mentioned, there are certain genetic predispositions. So, for example, South Asian ancestry is one of those things known to lead to a higher risk of cardiovascular disease. So, for example, many people of Indian subcontinent descent have very low levels of HDL or good cholesterol, which seems to predispose them to earlier atherosclerotic complications. This slide shows how people die throughout North America, and I think it's kind of insightful. Even though we've made tremendous progress in cardiovascular disease, still about a third of all people in North America will die of complications of heart disease, stroke, or aneurysm. And here you can see that the biggest part of this pie chart is heart disease. 25% of people who die will die of that. You see stroke down here, which is 6.1%. And then the other category includes people who die of aneurysms and other complications of peripheral arterial disease. So you add all that up together, and more than 1 in 3 people in North America will die of cardiovascular disease. So getting back to this concept of prostate cancer and some of the things that we heard about in terms of hormone therapy, we get to some very, very interesting discussion points. And at one point, conventional medicine thought that estrogen replacement reduced heart disease risk. But it turns out that this idea did not prove correct in large trials. The HERS trial was a very large US government-sponsored trial that looked at using estrogen replacement in women postmenopausal, with the thought that women that were receiving estrogen would have some of the benefits that women tend to have with later onset of cardiovascular disease. But unfortunately, that didn't turn out to be the case. In fact, in the first year of the trial, women who are on estrogen rather than on a placebo control actually had more cardiovascular complications. And the HERS trial is not the only trial that looked at this particular issue. One of my favorite trials to talk about is a study that was actually done in the 1970s. And that study was called the Coronary Drug Project. And during that time, people were trying many, many different things to see if we can lower cholesterol, knowing that increased cholesterol caused increased cardiovascular risk. So at that time, there was a study that actually gave men estrogen to see whether or not we can be more like women. So, some people would argue that might be a good idea, that men would be more like women. But in the case of estrogen and heart disease, it didn't work out. Men that received estrogen didn't actually have less heart disease. They may have had other changes in their social behavior, perhaps, but that wasn't directly covered by the study. So there's been a lot of data that have looked at this issue of using hormones to reduce cardiovascular risk, but we really haven't found that that's the case. As you know, prostate cancer treatment often involves surgery or using medications that block the effect of androgens, such as testosterone. And unfortunately, when you block testosterone, that actually increases your cardiovascular risk. And I'm going to get to some more details about that momentarily. The other thing is that cancer treatments may raise cardiovascular risk factors and require offsetting heart disease prevention strategies. So things like cancer chemotherapeutic agents can raise your cardiovascular risk. Just going through surgery, if you needed to, for example, have a testicular procedure to remove your testicles to reduce your risk of disseminated prostate cancer, this puts people at risk of surgery and puts people at risk for post-surgical complications, which can be very significant in somebody that either has established cardiovascular disease or is at high risk for those complications. And of course, there are other considerations when hormonal therapies are used, which is not specifically related to cardiovascular disease, but important to people. Dr. Cooke covered some of these things, but lost interest in sex, erectile dysfunction, hot flashes, and bone fractures can occur when men with prostate cancer are treated with hormone therapies. So this slide is a little bit complicated, but I'm going to just get to some basics on it. And it comes from a very, very nice review article in Circulation, which is a very prominent journal of the American Heart Association. And it basically shows that there's a lot of different ways of blocking the effects of testosterone. But testosterone is not a good thing in people with prostate cancer because testosterone leads to cancer progression. So one of the cornerstone strategies of prostate cancer treatment is to get rid of testosterone. And here you can see it can be done with a number of different chemicals. And I'm not going to get into all these things, including estrogens here. It can be done with things that block the effects in the adrenal gland. It can be done through surgical castration, and it can be done with other newer gene-oriented therapies that get into the actual gene processing effects of testosterone. But any of these modalities can have some negative consequences on the cardiovascular system. And this is a summary slide from that same presentation showing that when you block testosterone, bad things happen. So your fat mass goes up, your lean body mass goes down, you become more resistant to the effects of insulin and have higher glucose. The lipids move in the wrong direction. You're more likely to get diabetes, you're more likely to get metabolic syndrome, and you're more likely to have thickening of the arterial walls. There's also potential effects on cardiac contraction and the cellular activation of atherosclerotic plaques that could lead to rupture and thrombosis. So all these things can have negative consequences and lead to higher likelihood of cardiovascular complications. So what do we do to avoid these complications? And the interesting thing about this is that these strategies don't apply just to prostate cancer people, but apply to all people that are at risk for cardiovascular disease. So some of the simple ones: don't smoke. It's not easy for some people, but we have a lot of effective ways to help people with this particular problem, whether it's nicotine replacement strategies or strategies that affect the brain and the urge to smoke or to get nicotine in the body. Moving your body is very, very important. Inactivity may be one of the worst things that we can do when we're at risk for cardiovascular disease. Get up and move. Sometimes it's difficult, but coming up with strategies and a schedule where you move for at least 30 minutes a day is extremely important. Heart healthy dieting. I know you have some wonderful fruits and vegetables in Jamaica and plenty of opportunity to have a heart healthy diet and find a healthy weight. Good quality sleep and stress management is certainly important. And then regular health screenings. You have great medical teams in Jamaica, and monitoring your blood pressure, your cholesterol levels, and making sure that you don't have diabetes or treating diabetes when you're diagnosed with it are all very important ways of preventing heart disease or preventing its progression. So one of the things we like to train our fellows and residents is what we call the ABCDE algorithm for cardiovascular disease prevention. And this again was in that Circulation article. So here you see the listing of all the things. So A is increased awareness, A for awareness of cardiovascular signs and symptoms. Aspirin has been shown to be beneficial. Interestingly, aspirin used in high-risk patients is extremely important. If you use it in a low-risk patient, it probably won't do anything. So again, identifying risk is really important. And in the high-risk people, getting them on aspirin is important. Getting the blood pressure below 140/90 is certainly one of our goals. In fact, many would argue that we should be going for a goal of less than 130/80 in the highest risk people. Getting that cholesterol down. We have lots of ways of treating that, but the most important way of treating it is with high intensity statin therapy. Unfortunately, statin drugs are now generic, so high intensity statin therapy can be acquired at a low cost, and it's been proved to be life-saving and also avoiding complications such as stroke. Stopping people from smoking or helping them stop smoking is really extraordinarily important. Frequent blood glucose monitoring under D for diabetes. Metformin for diabetes is considered the best drug certainly back in 2016, but we have some newer drugs that unfortunately are quite expensive that also seem to do very well for diabetics to reduce their cardiovascular risks. I won't go into details other than saying that one class is called GLP-1 agonists, and that works by a connection between the liver and the brain to make people feel full when they've eaten a meal. And there's also something called SGLT2 inhibitors, which actually helps the kidneys remove glucose into the urine. Diet is another D word that we've talked about, and using a diet that's rich in fruits and vegetables and whole grains is certainly something that we'd recommend. And avoidance of excessive alcohol is also something that we advise our patients. The adjective excessive is important there. And exercise, as I mentioned, is really important. So again, A, awareness and aspirin, B, blood pressure, C, cholesterol and cigarette, refraining from cigarette smoking, D, diet and diabetes, and E for exercise are the key elements. But I like to end my comments by saying cardiovascular disease prevention is not all doom and gloom. So as I mentioned, excess of alcohol is probably not in your best interest, but a glass of wine a day can be a wonderful way to extend your life. And one of my patients, when I mentioned this to you, said, if that's the case, I may live forever. So I'll share with you that light moment. And finally, this very interesting thing about growing older is that when you grow older and you do the right thing for your health and you live another year, you actually don't use up that year. So think about it like this. When you're 27 years old and you live another year and get to 28 years old, you actually use up almost a full year of life expectancy. But when you're 67 years old and you get to 68 years old, you only use up 2/3 of a year. So that means by staying healthy for a year, not only do you get a healthful year, but you get an additional 4 months on top of that. So that should be an additional incentive for staying healthy as you get a little bit older in life, and also give us some positive reinforcement for the things that we can do to make ourselves feel better, look better, and live more active lives. So in conclusion, cardiovascular disease is the leading cause of mortality in patients in North America and for prostate cancer patients. Patients diagnosed with prostate cancer generally have increased cardiovascular disease risk, and this risk can become worse due to their cancer treatment, the old double whammy. And a proactive approach to cardiovascular disease risk reduction and treatment can improve prognosis and a patient's experience and prolong their life. So I'm delighted to take any questions. And if we want to go through the answers to the CME questions, I'm delighted to do that as well. I do appreciate your attention.
But before you go into any questions, I saw 2 slides back where you spoke about longevity based on your age, not that one, the next one, the one before that. Yes, so what about a woman who is 71 going on 72? What happened to that? I didn't see it in your chart.
Well, we'd have a very long lecture if we gave every age statistics. But the theory is exactly the same. If you're 71 and you get to 72, you get more than just a year. You'll get a year and 4 months of life expectancy. So the concept is exactly the same.
And in good health and on no drugs at all.
Well,
So
again, yeah, well, there's drugs can have a place. So if you have high cholesterol, especially if you have genetically high cholesterol, I would strongly support using a statin drug to get you in the best possible shape. Similarly, if you have high blood pressure, which may be no fault of your own, then being on a diuretic or certain types of drug to protect your heart and protect yourself against a stroke is a very good way to go about things.
Okay, so now I know what to do as a 71-year-old going on to 72. Thanks again. But before we move on to any questions, no, let's have the questions first, Dr. Lisa, if that's okay. Let's have the question.
Right, so we're asking persons to use a question and answer to make it easier for us to see your questions. I want to thank Doc again for the presentation. That was amazing.
Yes.
Thank you so much. So,
I'm not seeing any questions right now. It was excellent, very detailed. Sam, are you seeing any questions?
Nope, not seeing any myself.
It was excellent and very detailed as usual, Dr. Koren.
Yeah,
my pleasure.
And the best joke I've heard in 10 minutes.
All right, so we're going to actually have 2 sponsors present at this time. One was Abbott, which had a problem with login. We actually used an old presentation, and one was Indus. I am going to do Indus first. So Sam, play Indus, and then we'll have Abbott set up to do their live one, if that's possible.
No problem. So we're gonna ask both of them to come in live. So Mr. Dianadan, it's your time, sir. Please share your screen.
There's a question
open your microphone.
Oh, there's a question. Somebody just posted a
Two
question.
questions.
Oh, so let me just take any questions. One is from Dr. Tollereed. Are there any trials looking at reducing cardiovascular risk in men with prostate cancer?
Yeah, it's a great question. And generally, one of the difficulties of running clinical trials is that we typically exclude cancer patients. The concern being is that there may be confounding of elements to their cancer treatment, but it actually has been allowed in the more recent studies. So while there haven't been studies specifically of prostate cancer patients, they have been allowed in the studies, and we have not seen any difference in the trends. But it's a great question, and something that some people have argued for is to do a cardiovascular outcome study specifically in patients that are recovering from prostate cancer or prostate cancer procedures or treatments.
I think
Sam, can you unmute Marshall, or I just read it because he has a follow-up question? Can you unmute him, or should I just read it?
sure. Well, you can read the first one and then I'll have him come in for a follow-up.
Is there a difference in the types of treatment on cardiovascular risk?
Are there differences in the treatments?
In the
Yeah.
types of treatment on
Sure.
cardiovascular
Yeah,
risk?
yeah, plenty, and certainly that's what I do day to day. So for example, we were involved in many of the studies looking at the different drugs for diabetes to determine if one was better than the other. And interestingly, the Food and Drug Administration of the US mandated certain safety studies with diabetic drugs just to make sure that the diabetic drugs didn't have any adverse effects in the heart or blood vessels. But in some cases, the drugs that we were looking at for safety purposes turned out to reduce congestive heart failure complications or reduced heart attacks and strokes. So in fact, in the US, there's been a big movement from the old forms of diabetes medication like sulfonylureas and metformin to the newer drugs that are called the GLP-1 agonists and the SGLT2 inhibitors. And that's based on lots of different studies that have shown the benefit of these particular classes of drugs on cardiovascular risk.
Okay, wait, I'm not sure we answered it, so let me see.
Yeah, Dr. Tollereed, you can speak. I see your microphone's
ahead.
open.
Okay, all right. My mic is open. Sorry, I didn't realize it. I was just asking.
Okay.
I'm asking a couple of questions because I'm working on something right now. So it was a good idea to get a chance to sort of brainstorm. The two things I'd wanted to ask about were about cardiac screening for prostate cancer patients. If there's any specific things other than just risk factor assessment, whether we should recommend any imaging or other studies in those patients as part of their general checkup. And then my last question was really around spironolactone therapy in men with prostate cancer, and whether that would be something that would be useful to think about in Jamaica, spironolactone or aldosterone blockade.
Sure. Yeah, two great questions. So I can tell you that we do recognize prostate cancer patients as being at higher cardiovascular risk. So a lot of them do get sent to cardiologists in the US. As a cardiologist in the US, I see these folks. More often than not, I'm seeing them prior to some sort of procedure. So if they were going to have either a castration procedure or some sort of prostate removal, prostatectomy procedure, they would come to me. But more generally, this group of patients should be looked at as higher cardiac risk. And I would personally recommend some sort of screening to look to see how high that risk is. Of course, you do the standard cardiovascular risk factors such as cholesterol, blood pressure, family history, blood sugar, et cetera. But you may want to do a stress test. You may want to get a coronary calcium count. You may want to do other things that can establish the risk more specifically in these high-risk people. And then as far as spironolactone is concerned, spironolactone is a drug that we use a lot in congestive heart failure. It has the side effect, as you probably know, of gynecomastia in men. So I tend to use the drug eplerenone, which is also an aldosterone blockade drug, which doesn't have that side effect. But spironolactone or drugs in that class certainly have a role in folks that have congestive heart failure. and more broadly are medicines that can reduce the blood pressure and do other good things. Of course, they are potassium sparing diuretics. So when you use them, you have to take great care in making sure that people don't have elevations in their serum potassium. And they're often used well in conjunction with thiazide diuretics or loop diuretics, which tend to lower serum potassium levels.
Okay, thanks again for that answer.
Thank you.
We'll try getting a couple more questions before going off.
Is that
There's one
Mr. Wright has a question? Damien?
No, let's before we go to Damien, let me just finish one who has been waiting here for a while and we skipped through her. Is red wine more effective in prevention than white wine? Because I've heard this question from the lay audience a lot, so I'd like him to address that, and then we'll go to Damien, right?
Yeah, red wine is better if you like red wine better. Yeah, there's a lot of debate about this, about if there's anything special about red wine, and honestly, the jury is out. But what we do know is that low to moderate amounts of alcohol seem to have a beneficial effect on your lipids and actually increase your expected survival. So if you look at life insurance tables, people that have 1 or 2 drinks per day on average are actually expected to live longer than people who don't drink at all. But if you get to the level of 4 to 6 drinks per day, then your life expectancy decreases again. So although there's been some discussion about red versus white wine, the truth is that we don't have any scientific data that distinguishes that, or quite frankly, other forms of alcohol at low to moderate doses.
Okay, thank you. You can unmute Damien, right?
No, just in addition to what Dr. Michael has said about eplerenone. So eplerenone is available in Jamaica as epnone. So I just wanted to let everyone know that.
Thank you.
By the way, how much is it? Because I know it's not on the hospital. When we order it, I have to send out people to buy it privately. Any idea? I meant to ask this. Costing?
Yeah, one
Damien?
second. Let me tell you the exact price. 1 second. It's less than $1,000 per month supply.
Oh, not bad.
That's
Thank you.
Jamaican dollars, right, Mr. Wright?
Yeah, man, it's $652 for a month supply with NHF card.
Okay, excellent,
So
excellent.
it's extremely affordable.
There was one comment that I wanted Michael to comment on that was in the chat. Female HRT, when not taken by mouth and at much lower doses that are than promulgated by mainstream and in estradiol or estrogen progesterone form, it works to be protective as per the Harvard study. You know anything?
Yeah, well, there's certainly been some debate about the results of the HERS trial, which is the most definitive, very large scale study, and some people have raised objections to it. When I finished my training in the early 90s, we would put all postmenopausal women on estrogen replacement for cardiovascular disease prevention. That was considered state of the art. And then the HERS trial came out. And remember, not only did it not prove to be effective, but there was actually harm to women in the first year. So that changed the mentality. And other people have argued maybe the progesterone is offsetting the benefits of estrogen. Maybe we got the doses wrong, synthetic estrogens versus natural estrogens. There's been lots of different discussion. But the fact is that we have this very robust trial result. And while these other things could be true, the conventional wisdom is that you don't use estrogen replacement therapy for cardiovascular risk reduction. There's other reasons to use it. And certainly those are very valid. So it's used for hot flashes and other things that are important to women. But in general, the current thinking is that we don't use it for cardiovascular disease prevention.
Okay. Thank you. I think we've covered. Am I missing anything, Sam or Magna?
Not from me. No.
Okay, we're going to turn it over to Sam, who is going to screen share with our sponsors.
Thank you so much. So wonderful presentation. Thank you to both of our presenters today and our wonderful moderators. Now we're going to hand over to one of our sponsors. And of course, without sponsors, we're going to be able to be here with you today. So we're going to go to Indus Life Sciences, and we're handing over to Mr. Dayanadan. Are you there, sir?
Yeah, afternoon, Mr. Sam. Thank you
Hey,
very much.
afternoon, man.
Yeah, I'm going to share the screen. Are you able to see?
Yes.
Thank you. Hope I am audible.
Yes, you are. We can hear you as well.
Yeah. Good afternoon. Thanks very much for JMHS as well as for the moderators, speakers, and also participants from Indus Life Sciences. Just want to refresh a couple of our brands. Many of you may be aware of these brands. For those who have not heard of it, probably my presentation will help you to understand these drugs better. So one is our drug which was launched last year, somewhere around 6, 7, 8 months from now. That's as you could see in the screen, is meant for patients who are suffering from heartburn, hyperacidity, gastritis, flatulence, acid reflux, and ulcer. So we have an antacid because we all know there's no need to always start with H2 receptor blocker, proton pump inhibitor, and sometimes a basic antacid also can help your patient. So if you desire to treat with an antacid, we have a nice new generation antacid. As because why we say it's a new generation, as currently there are plenty of brands available in the market. I'm not bashing any of these brands, all of them are good, but this brand that I'm going to brief you is the latest one. So to understand it, let's see the generation of antacids, how antacids has been evolved. The first generation antacids or the basic antacid that has been there for long, and the role of these basic antacids are meant to neutralize acidity, as because they offer the components of magnesium hydroxide, aluminum hydroxide, and magnesium trisilicate, but they had a drawback. They only helps to neutralize acidity, but other complications, as we saw in the first slide, if the patient has gas problem, or if they have a pain, or in fact, if they suffer from GERD or acid reflux or heartburn, the first generation antacid has no answer for that. Then came the second generation antacid, which has a little added advantage. They, apart from neutralizing acidity, they also help in terms of relieving excess gas like flatulence, as because they offer medications like dimethicone and simethicone, either one of them. And most of the antacids that we see currently in Caribbean, they are categorized as the second generation antacid. But unfortunately, the second generation antacids also has a drawback because they have nothing to do with GERD, which is quite common. Almost 6 out of 10 persons who suffer from ulcer may experience GERD and the heartburn associated with GERD. So for the first time in Caribbean, even though in the next slide you are seeing it as Jamaica, honestly, it is, you could read it as Caribbean. So we are the first company has introduced the third generation antacid, which is known as New Gel, and is available in Jamaica, available in Bahamas, Cayman, Barbados, and even in Guyana, it's available. And this is a unique ingredient, as you could see in the slide, alginic acid, which is basically an algae. And this algae, when the patient takes this antacid, the person takes this antacid, this algae alginic acid mixed with the stomach content and forms a foam that floats over the stomach content, and thereby prevents the acid movement from the stomach to the esophagus, the food pipe. Thereby the GERD and the heartburn associated with GERD is prevented. And this is the first antacid in Caribbean which offers the benefits of alginic acid with plus acid neutralizing medications like magnesium hydroxide, aluminum hydroxide, and magnesium trisilicate, and it has dimethicone, which helps to relieve the gas. And here also in this slide, one point I'd like to highlight is, if you can notice it, the acid neutralizing medications, aluminum hydroxide, magnesium hydroxide, and magnesium trisilicate, they all very balanced formula of 250 milligram each. The reason is that if any one of them is on higher concentration, it may either cause diarrhea or it may cause constipation. Because of it is in balanced formula in New Gel, that the incidence of diarrhea or constipation will not be there. So that's the benefit. And this brand New Gel, what you see, is safe in children and also in pregnancy. In pregnant mothers, any trimester for that matter, first, second, third trimester, it can be recommended. And you all must be seeing in the screen It's a sugar-free antacid. So safe in diabetes population. And it has a mint flavor, which has the digestive benefit. And it is over the counter down here in Caribbean. Any of these islands, if your prescription travels to any neighboring Caribbean country also, they will get it new gel. Or even if you just communicate to them by any media, they can get it without prescription too. In all these Caribbean countries, it is over the counter. So that's new gel. And we have an extension of new gel, which we also has a nickname for it called as mother of all antacid. And it actually justifies the name because this is the first antacid in Caribbean. Apart from offering alginic acid to stop the GERD episodes and neutralizing acidity and relieving gas, it has this pain relieving medication oxytocin, which is basically a mucoso-anesthetic agent. The oxytocin gives a coating to the stomach wall and thereby gastritis pain, ulcer pain, or stomach related pain, it can relieve. So I'm pretty sure all of doctors are aware of either lidocaine like that. It's also an anesthetic agent, oxytocin, mucoso-anesthetic agent. And the only caution or contraindication, I could put it that way, the new gel O is not recommended during pregnancy. If it is a pregnant mother, it's better to recommend new gel. A non-pregnant women and rest of the population, new gel O is good. Of course, is not recommended less than 12 years of age, new gel O. So this is the only thing. That's why this is the one of the best antacid with acid neutralizing medication for GERD, for gas, and also for pain. And you can combine new gel and new gel O with a regular anti-ulcerant medications like H2 receptor or proton pump inhibitor, because antacids are basically for symptomatic relief, fast symptomatic relief. And new gel O is also over the counter. So persons can buy from the pharmacies without prescription. And you could see in the pack, it is a 200 ml pack. And the cost of the plain new gel down in Jamaica, I mean, the new gel O is sold around $900 in most of the pharmacies. And the plain new gel is priced around $800. And this month, that is March 2023, we also introduced the smaller pack, which is 100 ml, is also available. They respectively $550 and $650 in the pharmacies. So that is also available. So we have two pack size, new gel 200 ml, new gel 100 ml, new gel O 200 ml, new gel O 100 ml is available. So this is the indications. So any of your patients require antacid, you can consider the latest one. That's why we coined as new generation antacid gel, new gel. This is a new generation antacid new gel. And next is, I just want to refresh one of our other OTC brand, which is for pain. As you could see here, this is called as a red heat spray. This is not a pill. This is not a gel. This is a spray. So meant for all these pain indications, as you could see in the screen, neck pain, back pain, so joint pain, knee pain, ligament pain, strain, arthritis pain. You can use this. This is the highlighting point of this spray is that is all natural. And it has extracts from plants. As you could see, it has eucalyptus oil, turpentine oil, methyl salicylate, menthol. And being a spray, it acts faster, and you normally spray it at the site of pain. So that's a benefit, and it works faster. So, and indications, we already discussed it. And it's also over the counter. Again, there's no need for prescription. The patient can buy without prescription from any of the pharmacies. Again, this is available in all Caribbean countries. I mean, English-speaking Caribbean countries, right from Jamaica to Cayman, Bahamas, of course, Barbados, and even Guyana too. And we have in two pack sizes, 43 and 150 ml. The price down in Jamaica, the 43 ml is sold around $300 to the patient, and the 150 ml is around $600 to the patients in the pharmacy. So that is our ready spray. We have a tagline: powerful like a real beer, safe like a teddy bear. Why we say safe like a teddy bear? It has all plant-based extracts, and powerful is very effective. So it's powerful like a real beer, safe like a teddy bear. And we have the gel capsitop. You all been supporting it. Thank you very much. And the last product being, we have been discussing about cancer and cardiovascular conditions. We have this protein with vitamins and minerals. That's our amino pep. So especially when your patients have any chronic condition and they feel fatigued, stressed out, please recommend the most comprehensive formula in Caribbean, which offers, all essential amino acids with vitamins, and it has zinc also is there for immunity booster, and tryptophan is one of the amino acids, works like a stress buster. So plus it has all other amino acids too, histidine, arginine, leucine, isoleucine, everything. So indication is quite wide, 18 months and above it can be recommended, and any age group. So it can have, and we coined the brand name Amino Pep. We have been telling that use a pep to your step, that's Amino Pep. So it comes as 200 ml pack. And normally the dose is 10 ml for adults once a day at bedtime, and kids 5 ml is sufficient. And compared to most other supplements, Amino Pep stands tall. So to boost your immunity, you can consider Amino Pep too. Thank you very much. That's my presentation. And I have my WhatsApp number. Any of you require any of the samples that we discussed today, just send a WhatsApp message. We'll try to reach, especially in Jamaica, I mean. So we'll arrange to deliver the samples to you. Thank you. Enjoy the rest of your day. Thanks, Mr. Sam.
That certainly is a pep to my step.
Thank you.
Thank you so much, Mr. Danadan. So earlier we had some internet issues with our next presenter, and we're going to invite him to just come and say a few words to us now. Paul Russell from Abbott, please, if you're there, go ahead and speak to us.
Okay.
There you go, you're unmuted, can hear you.
All right, are you seeing my screen with the Abbott A?
I've seen it with the Abbott A, yes.
Okay, good afternoon. As mentioned, my name is Paul Russell from Abbott Nutrition, and I'd like to thank the Jamaica Midlife Health Society for the opportunity to present at this medical symposium. Today, I'm speaking on Ensure and Glucerna, two of our nutritional drinks, which provide balanced nutrition for your patients. Let me first introduce Errol, who's a young man who is overweight, and he makes nutritionally poor choices and has some chronic conditions. Errol tends to be an emotional eater, eating all the wrong foods, which is not good when you're overweight. You have high cholesterol and you're living with hypertension. A national survey done in the United States reported that people with chronic conditions consumed on average 29% less protein, 20% more sugar, and 15% more fat, and 45% more sodium compared with dietary recommendations. To help Errol, he would need to replace a nutritionally poor meal with an Ensure Max Protein. Ensure Max Protein has 30 grams of high quality protein to help build muscle and also to help satisfy hunger. It's low in fat and cholesterol, has only 1 gram of sugar, and it's 150 calories per serving. And this will help Errol to manage his weight. It's an excellent source of vitamins, minerals to help support his immune support. Now let's look at another patient. Let's look at Miss Joyce. She's recovering from a setback. She's frail and she's not getting enough nutrition. Miss Joyce has problems getting up and moving around. She's been losing weight unintentionally, and she has decreased muscle strength. Studies show that after age 40, we tend to lose lean body mass at a rate of 8% per decade. And after age 70, we lose lean body mass at a rate of 15% per decade. In the United States, we're seeing that 40% of adults older than 50 may not be getting the required daily allowance of protein from their diet. And I would imagine that we could expect similar results from our Jamaicans, or probably even worse. So Ms. Joyce would need to add Ensure Complete to her diet to increase her protein and calorie intake. Ensure Complete has 30 grams of high quality protein along with 350 calories in a 10 fluid ounce serving to help Ms. Joyce retain her muscle mass. It's an excellent source of antioxidants, minerals, vitamins to support her immune system. It has 4 grams of fiber to assist with digestion, and it's an excellent source of omega-3 to support her heart. And let's also consider that for persons living with diabetes, life doesn't stop with diabetes. 50% of persons living with diabetes consume less than the required daily allowance of proteins. And this can be associated with overall poor diets, eating more carbohydrates, and more physical limitations. By increasing protein intake, people with diabetes can maintain their muscle, they can manage their weight, they can manage blood glucose, and they can manage their hunger. Glucerna shakes can help patients with diabetes support their nutritional goals. And I've taken the opportunity to include my business card with my cell 489-6093, and also my email address, which is paul.russell, spelled with 1 L, @abbott.com. So please contact me with any questions, queries, or concerns about any of Abbott's nutritional products. And I thank you for the opportunity to present to you. Over to you, Sam.
Thank you so much, Brother Paul, and thank you to all of our sponsors for making today possible. I hand back over now to co-moderators, Magdalena and Dr. Dawes. Over to you guys.
Thank you. Before you go, we have a lot of questions in the chat that they're having some problems with how the post-testing was going. So can you make sure you work on that? And the post-testing is now up too, correct?
The pre-test and post-test is up.
Yeah, but in the chat, people are having problems with the post-tests. Let me see.
152 persons have done the test so far.
Wow, wow, wow.
So I'm not sure what kind of an issue they could be having. If it is a scoring issue,
They said their names are being mixed up, and it says there's an error. Just look in the chat, about 3 people posted.
Sure.
Magdalena, I'm going to turn it back over to you. I just wanted to make sure we got that in.
Yes, thank you. Well, I have to give my closing learn and laugh session. So here is the last one. I used to get heartburn when I ate birthday cake until a doctor advised me to take the candles off first.
So you don't get any more heartburn. Is the candles causing the heartburn, I suppose?
Well, I don't know. I'll have to ask the doctor, and he's not here. So go right ahead, William and Morsi.
Oh, okay. What a wonderful afternoon. Actually, we are right. We have time to spare. Actually, it's the first time. And the presentations have been so in-depth, given in-depth, and very, very helpful. My special thanks to, I'm not doing the thanks, but I just want to thank Mr. Everton Anderson from National Health Fund for taking the time to come and open the symposium. And also, I'll take him on his promise that he's going to continue to partner with us the way ahead. All right. So, Ms. Anderson, I hope you are listening to me. I'll take your word for it. So here comes Dr. Tasha Cooke, who spoke about the importance of erectile dysfunction and treatment options. She spoke about psychological and social impact of erectile dysfunction. She went on and mentioned self-esteem and how it can affect our quality of life. She also spoke about negative impact on the female partner's sexual function. I wasn't thinking about that. That was something new to me. And that one of the impact is in our pockets, that medication cost, very, very expensive, very, very high. So these are some of the impact. Then she alluded to the difference between impotence and sterility and erectile dysfunction. We've been mixing up those terms every now and then. She mentioned that there was a similarity between erectile dysfunction and cardiovascular disease, process, if you look at the mechanism of action, how they are caused, they have similar mechanism of action, blood clotting and all that, and reduction of blood flow to the heart and to the penis. And therefore, the severity of erectile dysfunction correlates to the severity of cardiovascular disease or coronary artery disease in that case. Some of the causes of erectile dysfunction, she divided that in two. She said there were two types, the psychosocial causes and the organic causes, factors. And the psychosocial, anxiety could lead to ED, depression could, emotions, your emotions they relate to your relations, overweight, obesity, recreational drugs, alcohol, these all can impact or cause or worsen ED. On the other hand, organic factors, such as the vascular factors, hypertension, diabetes, some medications can also cause ED. Obesity, she mentioned smoking, and a reduction of testosterone, and in Jamaica, she says sickle cell disease, can also lead to erectile dysfunction through priapism. Some pelvic trauma, for example, if you have spinal accidents or surgeries, that can also lead to erectile dysfunction. And so surgical procedures and radiation therapy. Finally, she spoke about hypogonadism and the effects of hypogonadism and its relationship to erectile dysfunction. But before she ended, she went on and she mentioned some management procedures. And one was to correct the predisposing factors that we just mentioned, looking at lifestyles changes, healthy lifestyles, psychosexual treatment, especially counseling in those settings, and the non-invasive versus invasive options of treatment of ED. And last and not the least is specialist care, in which I refer to as specialist for care. A doctor usually would evaluate, you do the evaluations, your lab tests and all that. And then treatment could start with various modalities. One could be using oral tablets, the PDE5s, and the intracaverous injections. She mentioned the vacuum device, look very interesting, the vacuum device, but she said that some pros and cons, and one of the cons is that it doesn't bring about spontaneity in sexual activity. You know, you're ready, your partner is ready, you're going to take a tube to do some vacuum. It might just take the heat out at the moment. Penile implant was another one she mentioned, and urethral suppository, which has been kind of difficult to get in these settings with its side effects. Penile, the benefits of penile prosthesis are very, very reliable, but the challenges are that very expensive, ranging from 3,000 US to, is it 14,000 US in some cases? And that one of the challenges is that we as medical professionals, we have very poor knowledge of healthcare when it comes to ED and treatment outside oral therapy. Now, the fear of surgery for persons and its complication can also be a challenge, and changing our perception, both the doctor and the patient and the public, is a challenge because people have problems with these implants and surgery, all right? And last but not the least, the health insurance companies may not support these procedures at all. Finally, she mentioned penile rehabilitation, very, very comprehensive message. I haven't heard from that angle, even as a medical professional. And I thank you very much for that, for bringing us that topic. Very, very, very much thank you, MyTech Medical. Our second speaker was Dr. Koren, one of our own who was here before, and he twisted his, adjusted his presentation as cardiovascular disease in high-risk populations, lessons from prostatic cancer patients. Very interesting too. He looked at the cardiac risk factors, which could be modifiable and non-modifiable. You know, modifiable ones, the smoking and the cholesterol, controlling the cholesterol and the pressure and the sugar levels and your weight, physical activity. But there's some non-modifiable risk factors, which are like your hereditary, your age, your gender. And he had said prognosis of prostatic cancer, survivors of healthy men, was one thing, a risk factor that we have to think about. All right, as the cardiovascular risk factors will mean that you have low blood flow to the heart, to the brain, for example, thrombosis. He spoke about plaques in atherosclerosis, blocking the flow of blood. He spoke about heart enlargement, congestive heart failure, and aneurysm, which can even lead to rupture, and stroke. He mentioned myocardial. When people talk about cardiovascular disease, they want to know what is cardiovascular disease. It can affect the circulation or the heart. And so he mentioned myocardial infarction, he mentioned strokes, he mentioned peripheral artery disease, he mentioned congestive heart failure, chronic angina, and finally, he mentioned valvular heart disease, which all are considered as cardiovascular diseases. He reiterated that the Black people are more likely to suffer from stroke, cardiovascular diseases, and that we, or the CVD, the cardiovascular disease, can also lead to erectile dysfunction. So we Blacks out there, including me, we have to be very careful. And I hear Dr. Tolorida asking if we should include in our investigation, annual investigations, if we can identify persons who are having ED and CVD at the same time, so we can identify them early. And Dr. Koren had said something like treadmills and proper coronary calcium coronary count, the CCC, to find out the level of cholesterol around your heart, because that would have started a process from ED. Dr. Koren also mentioned prostate cancer risk factor as age is a cancer, prostate cancer risk. You wouldn't see persons less than 45 with prostate cancers, but once you advance 60, 65 and you have prostate cancer, then you start thinking of cardiovascular diseases too. Risk factors for prostate cancer, same as those for cardiovascular diseases. He said among the population he looked at those who have high cholesterol, metabolic syndrome, chronic kidney diseases, those with chronic inflammatory conditions like rheumatoid arthritis, psoriasis, HIV/AIDS, and also our ethnicity. He mentioned Southeast Asia, but right here in the Caribbean, we're also at risk because we are Blacks. And I hear the special population of young Black male professionals, and I'm going to repeat, young Black male professionals are the ones who are high risk of erectile dysfunction and cardiovascular disease at the same time. That's why we term this symposium the double dash. We have the dash, the prostate dash towards prostate cancer death, and also dash towards CVD death. That's a double or the triple one, as you may call it. Dr. Koren also mentioned that estrogen replacement therapy, which we used to use before, if you know what he mentioned in the 90s and in the early 2000s, actually can reduce, which we thought could reduce your cardiovascular disease, has been canceled. The HER studies trial was one of them, and that low testosterone could actually increase cardiovascular risk. He said cancer treatment may also increase cardiovascular risk, and CVD prevention would include the same as the one for erectile dysfunction, for example, smoking, exercise, heart healthy diets, good sleep, reduction of stress, regular screening, your blood pressure, your diabetes, and all that. And so he finally ended up giving us an ABCDE algorithm that we can always remember. And it says A is for awareness, that you may have a cardiovascular disease, whether you know or you don't know, you have to go to your doctor and find out. But the A can also be aspirin, and I added another one myself. So that's the algorithm, ABCD plus alcohol as part of the A's. And then we went to B, blood pressure. He mentioned cholesterol, which is C, and cigarettes. At the same time, he mentioned D, diabetes and diet. I suppose alcohol will fall under that. And E as exercise. Very comprehensive indeed. Both presenters, very, very high cutting edge. Whether a medical doctor or not a medical doctor, you would have learned a lot from this session. JMHS is growing. We are touching hearts and minds. We are touching brains, actually. And we are educating the public, the general public, which is our mandate. And I thank all my colleagues who have worked tirelessly for the last maybe 3 months or more on this topic. It has been rough, but we have been made better in our presentation. Look at the time, look at the numbers. We had to spill over into YouTube because we outnumbered our quota. Thank you all, and I'm going to pass the mic to our precious secretary, executive secretary, who made all this happen under her watch. Marcy, can you take over? Thank you.
Thank you very much, William. It's my pleasure to do so. And I'll go straight ahead to my vote of thanks. Our special attendees, we are at the beginning of another dynamic health-focused series of JMHS's CME-accredited webinar symposia. Our sincere appreciation to everyone who has assisted in making our first webinar a tremendous success. Thanks to Magdalena Cooper-Denus, our Assistant Public Relations Officer, who humbly and fervently invited the presence of God into our midst. To the distinguished Mr. Everton Anderson, CEO of the National Health Fund, thank you for accepting our invitation to perform the official opening of this webinar symposium. Your greetings and commendations were laudable and warmly appreciated. Thanks to our dedicated and hardworking President, Dr. William Brown, who continues to be very impactful in his welcoming address and his closing remarks. Sincere appreciation to our prominent, accomplished, and distinguished webinar speakers, Dr. Tasha Cooke and Dr. Michael Koren, for providing in-depth, valuable, and welcomed information on erectile dysfunction, expanding treatment options, and preventing cardiovascular diseases in midlife and beyond, respectively. Thanks to JMHS's affable public relations officer, Rosine Greenwood, and Vice President, Dr. Lisa Kervin-Dawes, who notably introduced Dr. Tasha Cooke and Dr. Michael Koren, respectively. Thanks to our moderators, Vice President, Dr. Lisa Kervin-Dawes, and Assistant Public Relations Officer, Mrs. Magdalena Cooper-Denus, whose effortless ability to capture interest throughout the webinar continues to be very impressive and commendable. We deeply appreciate our invaluable, dedicated sponsors and partners. MyTech Medical, our platinum sponsor, who not only sponsored and provided the speaker, Dr. Tasha Cooke, but sponsored the first session of the webinar. Abbott Nutrition, Indus Life Services Limited, MedImpex Jamaica Limited, MSN Pharma. The highlights presented by their exemplary representatives were well received, and their products are available in pharmacies island-wide. National Health Fund's information was welcomed, and the services that they provide are incredible. Sponsors, today, you have immensely contributed to the success of this webinar. Without your contribution, it would be an impossible feat. Thanks to the Jamaica Observer for your committed, consistent, and valuable contribution to the JMHS. Thanks to our dynamic social media marketing officer, Amor Rickman, for her stalwart contribution. Thanks to our dedicated IT webinar specialist, Oldgate Solutions, for their impressive online services, especially at today's webinar. To our executive committee members, an impressive dream team, thank you for your consummate performance at today's webinar symposium. Ladies and gentlemen, we sincerely hope that you will join us at our remaining webinars for 2023, which will be convened on June 25 and September 24, respectively, where we will be addressing other vital health issues that impact our seniors at midlife and beyond. May God's presence, His unfathomable love and protection be with you and your families. Thank you
so much. All right,
Thank
so
you.
I leave the final words to our moderators.
Yes, I thoroughly enjoyed myself. I think I hope that Dr. Koren doesn't mind me saying this, and Dr. Who is our initial presenter?
Tasha Cooke. Tasha
Yes,
Cooke.
yes, I just enjoyed learning so much about the male part called the penis. It was a really interesting discussion. I think more women need to know that, so we know how to treat our men. I really enjoyed. Thanks to everybody. Over to you, Lisa, for the final word.
I was just that I actually learned a lot. I think we all learned a lot. Thanks for our audience. They were very interested and communicative. And I think it was an excellent webinar. We're improving as we go along, I'm saying.
Can
And
I
thanks for everyone.
Can I interject? Can I interject? There are two questions that were not answered that relates to Dr. Cooke that came after when we're closing off. Did you see it?
It was after her session. I am not sure if we can still do that now.
It's gone, missing from
She's gone.
It's gone from the question and answer. She's still on. I asked her to wait.
Still on?
Yes, I asked her to wait, but I noticed that it's now missing from the question and answer chat.
So they're missing? Because I didn't see.
Yeah, there were two questions. They're missing now. It's okay.
Oh, because I don't see them.
Yeah, gone.
Okay.
Okay, Dr. Cooke, thank you.
Well, thanks again, everybody. I think everybody made this a great seminar. Magna, pleasure as usual. Everybody, we help out each other as usual.
Can I just say, RGR would like to thank the RGR group for helping us out with advertising our webinar at this, was it earlier this month. Would like to thank them very much for their support.
And GIS also, we keep on forgetting GIS. I did 2 interviews for them. They hasn't come on board yet. And Jamaica Observer, GIS. All right, thank you.
And Jerry had one too. That helped us out a bit too.
Yes.
And Palav.
Yes.
Mm-hmm.
Thanks again to everybody.
Thank you very much.
Evening and have a good week.
Good. Very, very good. And look at the time. We've made the time, 30 minutes more. Very good with the recording, pre-recording presentation, the best way to go, eh? So let's keep it that way.
Thank you to all our attendees. We could not have done it without you. Thank you again. Please email jmhs.official@gmail.com for all your CME requests. Thank you.
Thank you, Amoy. Bye, everybody.